So what are the purpose and objectives of KCM? So KCM is a CCM, which is a structure established by the Global Fund, country coordinating mechanisms is what CCM is. So the one in Kenya, we call it KCM. So the purpose is constituency engagement. One of the strategic objectives is to engage the various constituencies that receive and benefit funding from the Global Fund, just to see that we are meeting their requirements, we are representing them in decision making, they are able to evaluate and give feedback about how the Global Fund program is being implemented to their members. And so really it's a mechanism, it's a coordinating mechanism to get feedback from the constituencies. We want to strengthen and sustain the Global Fund programming in Kenya, and so we then must get feedback from the ground about our work. So our specific objectives of this engagement forum, so this particular one, we're engaging with you as formal sector because you're one of our constituencies. We want to update you on the KCM Evolution Project. That is a project to update the governance structure of KCM. We want to tell you about the 7th Global Fund Replenishment. That is a round of funding globally that funds the Global Fund. We want to tell you about implementation of the grant in our country through the recipients who have received the money and they're here. We want to discuss achievements, challenges, success stories, and we want to discuss the constituency report, or rather our engagement today will contribute towards making a report from formal private sector. So we at Global Fund, we are guided in our governance through our mission and vision, our strategy, our principles. We have a strategic plan. And really we fund the diseases that people call ATM, AIDS, TB and malaria. We were established in 2002 and we invest $4 billion a year. Our mission is to attract and leverage resources to end the epidemics of HIV, TB and malaria. You will see in the updates today that the Global Fund has directed some funding to COVID-19 because it was found that COVID-19 is impacting the 3 main diseases that the Global Fund was established for. Our vision is a world free of the burden of HIV, TB, and malaria. So the Global Fund is a financing entity, not an implementing entity, and it exists at the global level and the country level in terms of governance and structure. The functions are resource mobilization and funds disbursements, implementation, monitoring and evaluation, accountability, audit and investigation. As part of accountability, we need to engage constituencies, and your feedback is very important to be captured in the reports that we shall give. So we have strategy 2023 to 2028 that is fighting pandemics and building a healthier and more equitable world. Obviously, this was then was coined because of the strains and stresses that the pandemic brought in the fight against HIV, TB, and malaria. Our key principles are partnerships, country ownership, performance-based funding, and transparency. So that's the Global Fund. How about the KCM? Our vision is optimal, accountable, and transparent stewardship towards ending epidemics of AIDS, TB, and malaria. And in our mission, we want to harness the full potential of partners and resources to fight those same 3 diseases. And so we are aligned with the vision and mission of the Global Fund. And really, as a summary of this slide, we exist to make sure that the funding that Kenya gets really goes to the right recipients and that their feedback is gained in informing the next round of implementation. So we want the fund to be as accountable as possible, the implementers to be as accountable as possible, and even the patients to be accountable in giving their feedback. So our functions as per our written constitution is coordinate approval, endorsement, and submission of funding to the Global Fund, to select the principal recipients, that's a big one for us, through a transparent and documented process. I believe the implementers, the principal recipients who present today will agree that the process was very transparent. To oversee the implementation of activities under the Global Fund approved program, to evaluate the performance of the grants, to ensure linkages between Global Fund assistance and other assistance and programs in line with national priorities. So we need, at the KCM, we need to have a bird's eye view of other funding that is also funding HIV, TB, malaria, and we identify synergies. Even as we evaluate the applications for principal recipients, we need to see that there's linkage and no duplicity in funding and strategies. And then a big one for us, and that's why it's bolded there, is to ensure that the constituencies are involved in decision-making process for the Global Fund grants. How the fund is implemented in Kenya is not determined in Geneva, where the Global Fund is. We are the ones as a KCM who determine and oversight that. We are chaired by the PS of Health. We have a vice chair that's drawn from the NGO constituency. And we have committees. We have a management committee, an ethics committee. We have the secretariat, and members of the secretariat are here, and that gives you an idea of our governance structure. In terms of the KCM membership, drawn from the constituencies, we have the national government, and the representation from national government within the KCM is drawn from the Ministry of Health, NAC, the National AIDS Control Council, the Treasury, KEMRI, and Ministry of Defense. We also have county governments. I think this is I would call it a recent constituent. I believe they've been part of the KCM since maybe the last 4 years. Is that correct? I think they're one of the latest additions. Obviously, because healthcare delivery in Kenya changed to a devolved structure at some point. We have the NGOs, and they have a member. We have FBOs. We have people living with disease. So across the 3 diseases, we have constituencies. We have development partners, both bilaterals and multilaterals. And then we have private sector. And in private sector, we have formal and informal private sector. So KHF sends 1 representative representing formal private sector, and then the informal private sector sends 1 representative. And then we have key populations and adolescents and youth. Now, these are principal members, and then we also have alternates. So every constituency sends, for instance, the national government 5 members and 5 alternates. Private sector 2 members and 2 alternates. So that at any one time, there's high chance of participation in the very many engagement forums and meetings that we have. So our strategic outcomes for the next 5 years is 1, strengthened engagement. So please give us as much feedback as possible in this engagement forum. Effective use of available resources, improved quality of services and grant performance. So there is some funding that comes to the KCM as a KCM, not just, the money doesn't just go to the implementers of the fund. There's also money that comes to KCM to run our operations, and we want to use those funds effectively. And then we want alignment and harmonization in delivery of results. So that's a busy slide. It just shows the achievements so far of the Global Fund in Kenya. And I think what will be more important is for you to hear the actual implementers presenting to you what they've done. Now, I would like to call a little later on somebody from the KCM office to talk about the 7th Global Fund Replenishment at the global level and what that means for Kenya. So I'm going to skip this because somebody will come and talk about it. Now, As part of strengthening governance at KCM, we're having what we call the KCM Evolution Project. And we want to be better aligned with national structures in the way we operate. We want to be really focused on investment results. We want to show the Global Fund, a return on investment that is worthwhile for investing in Kenya. And we want to strengthen our governance structure. So what we did is we identified the issues that we were having in Kenya in implementation of the fund and in governance of the KCM. And we gave feedback to the Global Fund because they had sent a consultant to see how better can you run your CCM as Kenya. And we had several meetings, and these are some of the findings that were found. The tenure sometimes is too short of the members, and then there's no traction. So as soon as somebody is a member, Global Fund has so many documents to go through, so many structures to understand, so many engagement forums. By the time you're just getting a grip of it, your term is over and somebody else comes in. And then we found that our constituency engagement meetings were under-resourced, and we need a little bit more funding to the KCM itself. But we also found good things, what is indicated as a plus. The participation is good. The engagement from the different constituencies is very good. We behave like Kenyans on Twitter. We give feedback all the time. We have WhatsApp groups, we have a lot of meetings, and everybody speaks. Whether you're from the smallest constituency or whether you're from the National Treasury, it's a free space, and we found that that's a good thing. We scored highly in that evaluation. And election or selection of membership is well organized and documented. It's not haphazard or ad hoc. So we identified some priority areas, and possibly maybe the one that stands out is the review of the CCM composition. And these are really activities that we want to do to strengthen the KCM. So the evolution of the governance structures is ongoing, and I can tell you that it's a very inclusive process. And at this point, I want to call somebody from the KCM office, Ms. Margaret Mundia, to give us updates on the 7th Global Fund Replenishment that you see on your program. After she gives us those updates, she will take questions. If you have specific questions, those that will be answered by the actual implementers, she will tell you, but feel free to ask any question or give any remarks. So please welcome Margaret Mundia.
Good afternoon, everyone. My name is Margaret, like you have been told, from the Global Fund Kenya Coordinating Mechanism. Like Dr. Daniela has just taken you through, the Global Fund is a mechanism that is here to support us, or to support countries, who we call the implementer countries. Initially, it was just in the support for HIV, TB, and malaria. Then, after many years, came what we call the resilience and sustainable systems for health, and most recently, pandemics with COVID-19. So I will try and just take you through what is new in the Global Fund currently, and that is the replenishment. The Global Fund depends on donors and other well-wishers to put together resources that is in turn sent to countries, or to help countries like ours. In Africa, the Global Fund supports countries both in Eastern and Southern Africa. When I say Eastern and Southern, is because we have countries that are outside East Africa, what we know as East Africa, and in Western Central Africa. So the replenishment that is going to happen this year is the 7th replenishment, and it happens after every 3 years. It's a 3-year cycle. So this year, there is a replenishment cycle that will be happening in, sorry, these I had to put together quickly after we agreed with Dr. Daniela that I take it off her slides. So if you see some typos, please just bear with me. And like where I come from, when somebody knows that they are not good in what they are doing, they say, don't listen to the voice, just listen to the words. So that's the same thing I'm going to request. So don't look at the slides because I can see there are some typos from my laptop. So there we are. So Global Fund always normally has a replenishment cycle after every 3 years. The last one was in 2019 in France. It was hosted by President Macron. And the 2022, please do it for me. The 2022 replenishment will be hosted by the US President, Joe Biden. And it will be in November in Washington, DC. That is the replenishment conference. But the call for the replenishment was hosted by 5 African presidents on the 23rd of February. That is Kenya, Rwanda, South Africa, DRC, and Senegal. It was all virtual because of COVID, so even the Washington one will be COVID, if COVID allows us to be together in one room, then we'll have it in Washington, but otherwise we'll just have to follow it virtually. So why are we talking to you about the replenishment? We are talking to you about the replenishment because as a country, we've always contributed, or rather the Kenya government has always contributed. And in the last 4 cycles, this is how Kenya contributed. The first time, it was 800,273 USDs. Then we upgraded to 2 million in the 4th replenishment. 5th replenishment, we gave 5 million. And 6th replenishment, we gave 6 million. We requested the presidents during the call for the replenishment in February if they can increase this money. And Global Fund was looking so much at African countries taking lead in this, not because they are the major implementers or consumers of this money, but because from Africa there is a lot. And I've just been having a conversation with some people in this room right now on what the private sector can also bring on board or can bring to the table. That is why we are making this presentation to you. It is an appeal actually, and we are asking what can the private sector, what can KHF and its team lead in making this happen for the Global Fund, because we all know that these funds have helped us a lot. And even as we do this, we have also been asking, what else can also the private sector get from this? That is a question that I was not sent to discuss here, but I just want to jog your minds. It has to be bidirectional as much as possible. We have what it takes. We can do so much, not just in Kenya, but in the region. We can see what the Africa Medicines is now doing, and we have vaccines being manufactured in the region. And there's a lot more. I've just met somebody in this room today who is WHO accredited. How can we get more of the people in this room? And what do we need to do? So those are conversations that I would like us to have as the Kenya Healthcare Federation. And also to tell you that there is a constituency which has a very big say and has voting rights on the Global Fund Board called the private sector. Currently, it's chaired by somebody in South Africa called Charles Sherwin. These are extra details. And it would be good if we also KHF became members of the private sector constituency, so that you also sit and make decisions that now go directly, not go through the country CCM only. So you should be at the table also, not as the menu, but as the partakers. So how are we going to do this? Dr. Nyalita and I have just agreed that we are going to have a conversation beyond this. And we see how we can make sure that our KHF is also in the Global Fund arena through the private sector constituency. And let us not try to go it alone, because we need the strength of numbers. There is voting everywhere, so even in that constituency there is voting. If we ever want one of our own to become the representative at the Global Fund, then you'll need others to vote for you. So don't go it alone. Let us make sure that we work towards this. So I came to give you this information and to also challenge you as a constituency, because there is a lot out there. Other countries have been enjoying this. Maybe I'll also again go back to the same thing I had as I was growing up. God's timing is the best. So maybe this is the right time for KHF. And with that, I wish to finish my presentation. Maybe if there's anyone with a question, not technical.
Okay, so I think instead of asking the question, I'll do a presentation, since I'm allowed by Dr. Nyalita. I'll do a presentation instead,
Okay.
instead of the question.
Okay. Thank you.
To introduce myself, my name is Palu Danani from a company known as Universal Corporation based in Kikuyu. And we have been WHO pre-qualified for the past 11 years. And those of you who know, it is like a certification. It's not a hit and run, you have to maintain it. So we have successfully maintained this for 11 years, which means quality production is possible to do in this part of the world. So I'll start with some few challenges, but first I must say, as a local manufacturer, I think the government of Kenya has done a lot, and we really appreciate in the Buy Kenya, Bin Kenya policy, and things that go with it. I think most of us know that Kenya is soon, I mean, it's not soon, it's in low middle income. It's no longer low income country. So a lot of fringe benefits are going to go with that, as well as donor funding. So we need to start building capacity in many areas in this part of the world. In space of HIV, malaria, and TB, if I take HIV as an example, 65% of the world's burden is in sub-Saharan Africa. And the manufacturing in this part of the world is, we would say, almost zero. One company in Uganda, Quality Chemicals, I think most of us would know, is the only company that is actually doing a bit of malaria and a bit of HIV, but it has got nothing in terms of the bigger numbers. So if I'm allowed, maybe if you can put up the presentation, I'll just go through the challenges as a local manufacturer. Oh, thanks. So I think I sent you the wrong one. Anyway, so just as an example, there was a recent tender advertised by the Global Fund, and it was a $40 million contract, and we lost because of 0.5% in price. Now, in reality, what does it mean? Loss of employment, foreign exchange, accessibility, because once the product you're relying on import, I think we all know where the product is manufactured nearer the problem, the accessibility is better. What are the differences here? I think this has something to do with our own government directives, initiatives, which we need help. We pay an import levy of 3% when we import the raw materials. And you can see we lost on a difference of 0.5%. So the government will not earn anything. So the 3% which they were expecting will not go to them, because the product is now fully imported with full exemptions when no taxes are being paid. 5 people will be employed to offload the container for 2 days. That's the only employment we're going to create. So I think we need some sort of assistance from whoever necessary to remove these levies and taxes which are regressing our growth. There is a current tender from the Global Fund, which is out. And if we do not do something about the taxes, we will be again locked out for another 3 to 4 years, because it's, as you know, Global Fund tenders are for 3 to 4 years. And a good example is during COVID times, we all know about the logistical delays. I would proudly say that we were supplying a product to 22 African countries from Kenya. That product did not go out of stock in any of those countries. Yes, there were delays, but nobody ran out of stock. And all the countries that were relying on imports from outside the continent had shortages of those items. So it shows how important it is to have manufacturing of essential commodities in this part of the world. And especially when 65% of the burden of whatever pandemic we are talking about is in sub-Saharan Africa. Maybe if you can go to the, one of the, not the word paper. So there are some subsidies that importers, or let's say manufacturers outside here get, especially when we are talking our competition only comes from the East. So India, China, Bangladesh has got huge amounts of export compensation that is given. So this is just one example of HIV. The market size, as you can see, is about $1.3 billion. And if I say 65% burden is in sub-Saharan Africa, it comes to $1 billion. And this is an example where I've taken the dollar at 100 to make things easier. In a nutshell, what we are trying to say is the government revenue will increase by 6 billion shillings in terms of taxes. And employment, direct and indirect, will have 16,000 only for this if the entire thing was bought from the region. Now, with this development, if the volumes are available, obviously the ingredients would be manufactured here. So there is a tab known as ARV API. If you can just go to that tab. So this would create another 10,000 employment for 10,000 people, an additional government revenue of 4.3 billion. And I'm talking of one item only. Why I say this and how we derive the number, we are taking an example of an existing company with an existing turnover and see how many more companies we need and how many will be employed, and more ancillary industries will be formed. Likewise, we have malaria done. So only on 2 products, if you can just go to the summary slide. I don't have much, I think I don't waste much of time, but just to show you, the total revenue in terms of foreign exchange that will come into the country is 1.3 billion, including ARV and malaria only. I'm not talking anything about non-communicable diseases, no other product. Total government revenue comes to 13 billion shillings from both those. Now, why, if you see, I've put an export subsidy. This is now, if we don't have an export subsidy, we will still not be able to completely fight our counterparts, and this export subsidy can be gradually reduced as we become more efficient. Despite giving an export subsidy, there'll still be an earning of 3.4 billion and 37,000 jobs being created only with those 2 items. I don't think I need to elaborate more on how many more items can be manufactured. So these are some of the challenges we face and what help we need. But I would also say that Global Fund really has a huge drive towards domestic production. So definitely that also is appreciation, and Global Fund actually helped these 22 African countries because that was under a Global Fund contract that we supplied from here. So I guess a little more is required if Global Fund could look at, and being in Africa, there's a little bit of more expensive in terms of manufacturing, but it's not alarming. It's not that we are 20%, 30% more higher. We could be 1.5% more higher in manufacturing than our counterpart. We could be. I don't think there's any data to show that we are much more higher than that, but I'm sure it can be competitive, and in a few years, as efficiency grows, even that 1.5% can be catered for. So I'll stop there, and just a last quick presentation on Universal. There's slides. So we are part of a company known as Strides, a global multinational. And our focus is to differentiate space in the generic industry. Next slide. This is just a history about who is Universal. We started in the year 2000. 2005 and 2008, we had rounds of investment from FinFund, which is a Finnish industrial development agency, which actually helped us to get the WHO pre-qualification. So they left in 2015, and we merged with Strides in 2016. Why did we merge? In this space, to develop one ARV will cost you between $1 to $4 million, depending on the cost of the API. Now, being in Africa, when you don't have a market, and to invest that sort of money is not going to be easy, and nobody's going to fund it. So we needed a bigger brother where we could rely on a product that is ready and do a technology transfer. So that is the reason for the merger with Strides. We are based in Kikuyu, and we've been pre-qualified since 2011. This needs to change. It's now 11 years because we don't have, the last report should come out very soon. After that, we'll change it to 11 years. Next slide. I think I don't want to introduce Strides, just go on. So this is again a global thing, just go on. Carry on. So we are in 23 years of experience, over 100 products. We are in 19 plus countries, 400 plus employees, today 500, and many other approvals apart from WHO. Carry on. Our capacity, if you move to the next slide. Our capacity is not small as well. We can produce 3 billion tablets as we talk now, which can cater for entire requirement for the region, and capsules and ORS, and that's all, including the other inspections we've shown on the slide. Please move on. What makes us different, and what is giving the confidence to the regulators? Our entire quality management system, including the trainings of our people, are based on IT and interlinked. So that gives the confidence to the quality guys that there is no manipulation of data that can happen. So all these are the softwares that we use. Can you move on? And what makes us different? I mean, these are the products that we have already got pre-qualified by WHO. We've got both the first-line treatments for malaria and HIV. And we are now developing a dispersible sulfadoxine pyrimethamine, which is for intermittent pregnancy, and sulfadoxine pyrimethamine with amodiaquine. And this is going to be dispersible. I think what we get here today is the normal conventional one and not dispersible. Move on. Here, the only thing I'd like to elaborate on is the partnership with UNICEF. We have developed 2 products with UNICEF for the betterment of children, and we are doing it at, you could not say almost free, but cost plus, just to make sure that we get more treatments out there possible. Like the COPAC, we do about 20 million treatments a year. And the chlorhexidine gel for umbilical cord care, we also do about 3 to 4 million a year. Can we move on? We have a good training program. I mean, just as an example, and we always say that we don't have skills. But I think with a good trainee program, we can do it. In the year 2015, we had 15 expatriates. We are now down to 5. So we train people from all, not only in pharmacy, but if you go to the next slide, engineering, QA, finance, IT, supply chain, across the board. And once you go through the trainee program, and if you're not bonded, if you want to leave, you leave. If you have a vacancy, we take you on. And people in management level, once they get to management level, we have something, if you go to the next slide. We also have a future leadership program, because the technical people also need commercial skills. When you get to management level, you need both. So this program has really worked, and I said from 15 expatriates, we're down to 5. So it is possible, and skills can be developed. We have a lot of brain power. The only difference is they do not have the right training to understand GMP for today. Thank you. I think I've covered everything. Thank you very much. Unless questions.
Thank you, Palu, for that thought-provoking presentation. I hope when we have our own representative on the Global Fund Global Board, they can make decisions in favor of preferential procurement from our countries to boost our local manufacturing. Okay, I think it's time to now call the the recipients to make their presentations. So the first one is the National Treasury. Karibu sana, please introduce yourself and make your presentation.
Okay, thank you very much. The country coordinating mechanism, all the partners who are around. My name is Anthony Miru. I'm from the National Treasury, the GF Program Monitoring Unit at the National Treasury. So the National Treasury is the principal recipient one, or the state PR, and as the KCM presenter had said, we normally have the grant has the state principal recipient, and then we have the non-state principal recipient. So the National Treasury here represented is a state principal recipient. So our sub-recipients, again, for the PR, we do not implement the grant activities. We usually do this through the sub-recipients. And as somebody had alluded before, we used to have, we normally concentrate on three disease areas. That is HIV, TB, and malaria. And our principal, our sub-recipient for this matter is the Ministry of Health through the various divisions. For example, we have the TB unit at the Ministry of Health, and then we have the HIV, that is NASCOP. Then we have the Division of National Malaria Control Program. And of late, we were added one more sub-recipient called the HSSD, that is the Health Systems Strengthening Department. And then the other sub-recipient is National AIDS Control Council. And then, I'm just giving you an overview of how things look like for the state PR. We also have a procurement agency. We have an MOU with KEMSA because most of our funds as a PR goes to procurement of commodities. So KEMSA, we have an MOU with KEMSA, and they do procurement on behalf of the National Treasury. Next slide, please. So this is how I'm going to do my presentation. I'm going to show you for the current grant, it is called the new funding model 3. We used to have rounds of grants, but the rounds ended, and then we started the new funding model 1. The last one that ended in last year, that was 2021, was the new funding model 2. And then from 2021, I think, until 2024, we have the NFM 3. So when you hear me talking about NFM, just know it is this current round of grant. But I'll still show you a snapshot of what happened in the previous NFM 2. So this is the way I'm going to do my presentation: programmatic, then you'd go to financial, and then a brief of the procurement and supply chain management. And then I'll show you some of our PR oversight activities, and then some of the key challenges and the mitigation measures that we have put in place. I'm not sure I'm going to read all these, but in a snapshot, I just wanted to show you. I'll start with the HIV program. So this is for the period between June 2021 until December. We call it a semester update. And you can see there are key indicators that we were being measured on by the Global Fund. So when we are doing our semester report, there were targets that were set for the performance framework, and specific indicators for the same. I'm not going to go through each one of them, but you can see how, for example, for the HIV program, how the performance is. And this is what happened until December, for the period of 6 months until December last year. But if you want the specific details, I think I've shared the presentation so that I don't take a lot of your time. Next, please. Again, for HIV, other indicators like PMTCT indicators, number of VMMC and the challenges, because at the comment section, if an indicator is performing below, we will tell you why. If an indicator was performing above, again, we are able to go to the DHIS and tell you why this perform. Okay, because most of our data here is coming from routine data. So you go to DHIS and you will confirm that this is actually what was happening. But then in the comment section, we try and explain why if an indicator was performing below or it was overperforming. Next, please. For TB program, these were the indicators that were being tracked, like for example, the case notification rate, percentage of health facilities with treasure medicines for the 3 diseases, and the like. Again, I'm not going to go through, the presentation is there, but you can see at the comment section, if you see the results, we have explained why the performance was like that. Next, please. TB continued. The next. So for malaria, again, these are indicators that are being tracked. For example, confirmed malaria cases, whether it is microscopy or through RDTs. Again, the results, and then the comment section. So basically, these are the indicators that were put in this grant, that the NFM3, for the next 3 years. And this is what we are being tracked as performance in the performance framework. So next, please. Then in summary, this is where I wanted to come because I didn't want to go through each and every grant. For example, in HIV grant, the key issues that were noted during the last semester is that we had erratic availability or stockouts of commodities. And then there were funding gaps, especially for VMMC, that is voluntary male circumcision. And then there were gaps again in patient-centered care. So there were a large number of lost to follow-up patients. So again, for each and every issue, we have given a mitigation measure. So what is being done to improve the performance where we felt there were critical gaps? For malaria, I want to touch on this issue of frequent stockouts of essential commodities. These were ALs and RDTs, and I want to explain that for malaria program and even the HIV program, the pipeline is a product of different key players. For example, there is the US government and the Global Fund. It is not only the Global Fund that contributes to the pipeline. So we had issues across board with the USAID funded commodities whereby they didn't have tax waivers for their commodities. This has since been resolved. And then if you look at the pipeline as it stands now, it is very, very full. And we are happy that the US government was able to get that waiver. So we have 2 pipelines, for example, in malaria, where commodities that are coming through the USAID funded commodity through PMI, they are being channeled to meds. They changed from KEMSA, and then the Global Fund granted commodities are coming through KEMSA. But you see the user is the same. So everything is coordinated by the program such that we don't have any gap. So for facilities, they don't know whether this comes from USAID or this comes from Global Fund. What they do is to request for commodities because these are demand-driven commodities, and then they are channeled to them accordingly. There is a logistician who does that. Next, please. So if we go to the finance performance, basically, I want to show you how we performed in the previous grant. And generally, you can see in terms of absorption of funds, the HIV program was able to get a 93% absorption, which was very commendable. TB, 91%, and malaria, 94%. If you look at the total grant budget that Global Fund had availed, this was 310, 963, 578 US dollars. So compared to the expenditure, which was 288, you can see generally Kenya was able to do 93%, grant absorption, which to us is an improvement of the previous grant. Next. So again, this is now in the new grant for the previous 6 months. You can see that if you look at absorption in terms of budget versus expenditure, you can see that in HIV, the budget for that specific period, that was 6 months from June, the budget was around $2.4 million US. But then the only expenditure was 851,812, which means that if you compare expenditure versus budget, it was coming to around 36% for the first 6 months. But if you include obligations and commitments, that is funds, the contracts that had been signed, and again, there are invoices that we have already received at the National Treasury, which were not captured, because you only capture expenditure when payment is done. But there are invoices that are there, that is what we call obligations, that have been forwarded. Then commitments is anything that has been contracted and that has been awarded. So if you look at like HIV, you can see there was a 729% absorption, and most of you will ask why. But this is because HIV were able to procure, to bring forward the year one procurement within the first semester, and that is why, against of their budget, they were able to bring a lot of procurements which were delivered, and they are being processed. The payment is being processed. So again, if you look at TB and malaria, we can talk about 77% absorption of funds for the first 6 months, and then for TB, 36% absorption. Next, please. So basically, this is what I was explaining, but graphically, that is budget versus expenditure versus commitments and obligations. Next, please. So if you look at, again, if we want to sum up the financial performance, the HIV, you can say that absorption as December 31st was at 36. But if you look at the contracts, which amounted to 36 million US, they had already been signed by the end of December, and deliveries amounting to around 16 million US had already been made. These are largely procurement of adult and pediatric antiretrovirals. Then TB, again, it was at 24% with commitments of around 0.6 million US. Then for malaria, again, if you look at budget versus expenditure, it was at 35%, around 36. And then there was a mass net distribution exercise, which was being paid from the NFM3. These had already been completed by December, but it had not been captured as expenditure. Again, if you capture that, the absorption again goes very high. Next, please. I want to touch briefly on procurement and supply chain updates. Next, please. If you look at NFM3, we were able to start procurement of, for example, for malaria, of around 2.6 million US. They had already been contracted, and deliveries, I believe, will start trickling in by the end of this month and in April. Again, rapid diagnostic test kits worth around $10,000 US, which we expect in the month of May. Next. TB, the same story. You can see what has been contracted. And again, this is the status. Some have been delivered, some have been contracted, and some deliveries are ongoing in stages, which sometimes are staggered. Next, please. Then ARVs. against a budget of that. You can see the status, like TLD has been fully delivered. Other 3 items have been contracted and the like. If you look at things like condoms, or 2.7, they are contracted and the deliveries are expected in May. So generally what we are saying, we are on course in terms of supply chain management or procurements. Next, please. And then the same story for other commodities in HIV. What I want to say is that for some items, some are being reevaluated, like the opioid substitution medicines, and then the reevaluation has already been completed, and we hope the process will continue normally. Next, please. Through Global Fund, again, there's something I didn't mention in the beginning. The country is supposed to contribute 20% of what Global Fund gives you through counterpart funding. And this is a status. And for TB, they had a budget of 250, 761. This is for the period between June 2021 to July 2022. So these commodities were at contracting stage. For malaria commodities, most of them have already been delivered because I had made this presentation earlier, but I know most of these commodities have been delivered. And then for HIV, with a budget of around 1.4, I think most of the ARVs are at notification stage, and the male condoms are at evaluation stage. Next, please. I had told you that we have an MOU with KEMSA because they are the ones who does our procurement. So we had to review the engagement, the MOU, and the status is that the MOU has already been finalized and has already been submitted to the Office of the Attorney General for legal clearance. And then KEMSA have developed a tracker whereby we will be able to determine performance against the key performance indicators. And then most of these key performance indicators are related to timelines of procurement. Next, please. This just shows you how everything is progressing in terms of submission of the year 2. We are in year 1, which ends in June, but you can see we want to be ahead, and you can see that we want to start the procurement of year 2, and year 2 is starting in July, but already if you look like for malaria, they have already done the quantification. It was already done in September. So the supply plans have been developed and submitted to us for review. So we want to work way ahead of time so that we don't have, because of the lessons learned, we learned from the previous grant. Next, please. COVID-19 procurements. Again, these were the allocations because Global Fund, when COVID struck, Global Fund said that we cannot be able to tackle the 3 diseases when we still have this issue of COVID. So they were good enough, and they granted this allocation to the country. And again, this is the status of these procurements that were awarded by Global Fund, specifically for COVID-19. Next, please. The same story. Next. Next, please. Yeah. HIV, yeah. Just go ahead. Some of these slides were for another forum. That is why they are so much detailed. That is why I'm skipping some of them. PR oversight activities. We are saying that as a PR, we have an SR, and our SR is a Ministry of Health. So we have to monitor how the malaria program is implementing the activities according to the grant document, how TB program is performing, and how HIV program is performing. So we have developed a schedule. Like, we have a monthly meeting every month with the program and see how we compare what they're supposed to have done and how far they are with all the activities. Yes. So again, I've talked about that. Next, please. Then if you look at what we have already done, like here you can see procurement status, we have already gone to KEMSA once. That was in January. If you look at the SRs, we have visited the HSSD. This is a new SR who needs a lot of support because they were not there previously when these other programs were there. And National Malaria Control Program. In terms of financial management, you can see where we have visited. And again, for KEMSA, again, we have been there once. That is since January this year. Next. So, these are some of the key performance challenges, like numerous competing activities among our personnel. So sometimes we have routine engagement with SRs and KEMSA. We also have our internal PMU administrative tasks and activities by other stakeholders, including KCM, which we work very closely with. So sometimes, what are some of the next steps is follow up on action areas that identify and improve on adherence to the oversight schedule that I had shown there before. Next, please. So the key challenges, generally or overally. Next, please. So some of the key challenges in the programmatic activities were slow implementation of programmatic activities, and then almost no programmatic activities were implemented in NFM3 Q1 period for all the SRs because we had delays in disbursement of funds from Global Fund. So most of the activities were not conducted. And then operationalization of the HSSD has been slow. This is a new SR. So again, we are trying to see how best we can support the department so that they're able to catch up. And then the other key challenge is the sub-recipients and the MOH yet to involve counties. We said at the beginning of this implementation period, we were to separate the county level activities specific to counties. We share with the counties so that all the SRs should share their work plans with the counties so that, again, the counties can start implementing what they're supposed to implement. That has been slow, but I know we are on top of it. We are trying to push the SRs so that they're able to incorporate the counties in their specific county activities. Yes, next. Is there anything else? Yeah. So some of the achievements, we can say the tax exemption master list, that is a must because Global Fund commodities or activities are supposed to be tax exempted. That one we have already been able to get. And then COVID-19, delays in delivery of commodities by month due to requirements for PVOC registration. These already in year 3, in NFM3, this has not been the case. And then we have increased the capacity of accounts department through secondment of accountants to some of our SRs because that has been a challenge in the previous grant implementation. I think with that, I want to stop there and ask if there are any issues, questions, clarifications.
Good afternoon, everyone. My name is Kenneth Ogendo. I work for Living Goods Kenya, and pleasure to be here. And that's indeed a great presentation on how Global Fund is supporting this country. Last time I checked, and I'm asking this question because I can see you are from Treasury, there was a call for Kenya to adopt the call to self-reliance. And I have also seen a slide there on co-financing. So to what extent is the Ministry of Health and the Ministry of Finance or Treasury planning to transit Kenya into that direction? What are the conversations and how prepared is Kenya for handling HIV, TB, malaria programming? Where are we at that? Thank you so much.
Thank you. You have partly helped me to answer that question, that one of the key inputs that the government has done through the National Treasury, which is a requirement by Global Fund, you can see over the grant periods, the government has been kind enough to have increased the core financing for this country. So if you look at the previous NFM and the current NFM, the government has really increased the money going to the counterpart funding. The other bit is that the Ministry of Health, through their MTEF, have been very keen, and we have seen that for TB, I think even for malaria and HIV, they have set aside a budget to support these three programs, which is a departure from the previous periods. So if you look at the MOH budget, and I think they had even called their staff for a workshop to really come up with the needs and what the government can support, again, through the Ministry of Health. Again, when we meet counties, we really encourage the counties to take up some of the traditional activities that were being financed by Global Fund. So by involving the counties, we have seen a lot of counties that have set aside money to support disease areas, not necessarily procurement of medicines and the like, even in terms of staff, employing staff where probably there were HR issues and the like. So I think through these three areas, I think we are moving towards sustainability.
Thank you, my brother. My name is Meshak Ndolo. I work for IQVIA, a global health consulting entity that's a member of KHF. I just wanted to ask something very briefly about the absorption rate. And when I look at the figures that you shared, 24% I think for malaria, TB, HIV, somewhere between 35 and 36. My mind goes into how as a country we can work together, both public and private sector, to improve the absorption rate of the Global Fund. When it's at that level, definitely there is concern, considering that this year we are very busy. We have a busy year, getting new leaders, so sometimes these activities, they tend to slow down implementation of public health programs. So I'm just asking two questions. One, are those figures for both commodities and service delivery in terms of absorption, or are they only for commodities, or are they only for service delivery? Because we do know that about nearly 80% of the Global Fund money goes to commodities. So I'm looking at the question of how can you disaggregate the absorption rate in terms of those two. The other question in terms of now working together as public-private sectors is, having disaggregated which figures are in which of those two categories, then because from where you sit at the National Treasury and Planning, you have big eyes. You see things from very high level, because you are very organized in terms of being able to capture data from many fronts. How can we, as private sector, benefit from some of the data you have that's pointing toward the direction of where there are weaknesses in terms of absorption? Is it us in private sector who are not supplying what you need quickly when you need those commodities? Or is it you who is not, as public sector, having a good plan and roadmap that can anticipate the timelines where commodities are needed and they should be delivered, and you get caught up? I'm just asking one question. It's a very small question, although I'm saying with so many words. Thank you.
Okay, thank you very much, Mr. Meshak, for that feedback. I'll start with the issue of absorption. if you look at those figures, where it was low, it was when it was just expenditure versus the budget. Meaning, whatever had been paid by December versus the accumulated budget for that period. But if you looked at the end, I was putting something called obligations and commitments. For example, I'll give you a very good example of malaria. If you look at the absorption at, I think, 34%, that was what was expensed, what had been captured in the books by December. However, we had very huge contracts that had been signed by December for procurement of anti-malarials. And other obligations means there were so many invoices that had been brought to the National Treasury that had not been paid for, but we could not capture them as expenditure. So when we combine expenditure and obligations plus commitment, the figure again changes, and I demonstrated that. The same for HIV. That is why the HIV, when you put commitment and obligation, it was coming to 729%. Because what the HIV program did, they were able to procure ARVs within the first year. They were able to bring forth the budget, and most of these commodities have already been delivered. So we learned from the previous grant not to be waiting for example, if the budget for year one has been put towards the end of the year, like for malaria, we had already submitted that by July to KEMSA. So by December, they had already done the contracting. So maybe the picture will look better when these deliveries are done. Like for anti-malarials year one, we are very sure by end of April, we'll have all the commodities in place. Again, to add on your second question, yes, it represents both procurements and services. Because in the first quarter, basically, except for the malaria program where we had mass net distribution countrywide, for these other programs, since we didn't have a lot of activities, we had foreseen that, and we didn't put a lot of activities in quarter one. So basically, the only absorption there was the normal salaries and things to run the program. But we had not put key activities in the first 3 months because of the lessons learned in the previous grant. Very important is the issue that you have brought forward for public-private, and I know you have been in this program and you have a wealth of experience in it. So if we critically look at the grant documents, the grant document has activities or modules, specific modules with specific activities, and if it is procurement, I think that is an opportunity, as you have said, because what KEMSA does or what MEDS are doing, they do international open tender. And I think, I'm not sure, there is somebody who was here, the gentleman from Kiku, who said they lost a bid because of, I think, 0.5 or something. So when you have an international tender, I'm not sure, maybe I heard Margaret talking about bringing on board some of the private sector on board to be part of, because I don't know, when an international, tender issues are very sensitive. So once it is put in place, I think they go for the lowest. But I don't know whether there are measures that the Kenya government can put so that they can, for me, I feel you can encourage our own industries or local mechanism. But I think that is something that should be looked up to, because again, I guess it is because of economies of scale that some of these small private entities are marshaled out of the competition. But I guess it's an area that can be explored and needs a lot of thought to it.
Thank you very much. My name is Andrew Nyandigisi from Health Strat, a member of KHF as well. Thank you, Anthony, for the presentation. It's quite clear and useful, and excited about the progress that has been made. On to my question in the interest of time. I think the question I think Meshach is asking is quite critical about the commitment of funding that goes towards our absorption rate. And I want to specifically touch on supply chain, on the deliveries. One of the biggest headaches I remember that the government used to grapple with is an issue of proof of delivery. When to show, before the Treasury could pay KEMSA, they needed to confirm that the commodities that they were tasked to deliver had actually been delivered. And I remember what used to happen is a huge consignment of paperwork would come to the programs, and somebody had to go through them to confirm that the delivery had happened. And I think this is an area that used to cause a lot of delays and therefore affect our absorption. My question is, what has been done to address that? Because as I speak, I do know that there are other technologies that have been actually developed that donors like World Bank, UNFPA are actually using to confirm deliveries at the facility level in real time. Is this something that the National Treasury has looked into? Because then it can shorten the turnaround time and also reduce a lot of the audit queries that otherwise follow such a confirmation. Thank you.
Thank you. I think I'll just point of clarification. When we said we were 0.5% more expensive, is because of the RDL and GOK that we are supposed to pay on import of raw materials, whereas the imported product gets full exemptions. So if we did not have to pay that to make it a level playing field, we would have been cheaper than the imported product. So it's not economies of scale, it's definitely our own taxes, which are not a level playing field against the imports. Thank you.
Okay, thank you very much, Andrew. And thank you for the clarification on the 0.5%. And the proof of delivery, Andrew, I'll tell you, I think the only thing has been done so far is just to have that acceptance and inspection committee that when the goods are delivered, they go to KEMSA, now from the ministry, and then they ascertain that those goods are there, such that when the paperwork to the head of the program, it is just a matter of him calling his committee and saying that these things are there. Because again, you know, for government, government is a bit bureaucratic, sometimes even with paperwork. But I appreciate that if there are opportunities whereby even KEMSA can be supported or other procurement agencies, I think this is the way to go. Yeah, I think this is the way to go, because even some of these bureaucratic systems we had, like now we are using M-Pesa even at the National Treasury. So I guess it's an opportunity, and it is something that I guess people who have that experience can bring forth, and we see how best this entity can be assisted. So it's a welcome idea. Thank you. Yeah.
Thank you very much.
Thank you.
Yeah. Thank you. Please, let's give him a round of applause. Thank you. Thank you. Thank you. Thank you. So, Kenya Red Cross.
Good afternoon, everyone. So, my name is Joyce Wanyonyi, and I'm presenting on behalf of Kenya Red Cross. So, please help me in moving the slides. So as you've been told earlier on, Kenya Red Cross is the principal recipient 2 of the Global Fund grant. The principal recipient number 1 is the National Treasury. He's just left the stage. And principal number 2 for the HIV grant, that is Kenya Red Cross. AMREF is the principal recipient 2 for malaria and HIV. So in terms of the grant updates, I'd like to give you the figures in terms of where we are. So those are the figures. We got 77% of the disbursement from Global Fund, and we spent 50%. Next. So that is the status in terms of what was disbursed to our partners. Currently, we are supporting 65 sub-recipients across the country. So we were able to disburse to them 98% of the grant that they had applied for, and the absorption, that is what they were able to spend against their signed budgets, was 63%. Next. So in terms of programmatic achievement, as Kenya Red Cross, there is what we've signed against the performance framework. So we have specific indicators that we do present to the donor, and that is the status in terms of the female sex workers who are able to be reached with comprehensive HIV prevention services, that is including the clinicals. We were at 96%. In terms of HIV testing, we were at 47%, and majorly because of lack of the test kits, that was shortage across the country. So in terms of those who are eligible for PrEP, because PrEP, we are also using it as a prevention measure, we were at 29%. And again, it's because of the erratic supply of the PrEP commodities and also the HIV testing kits, which goes hand in hand. For the MSM programming, we were able to reach 77% of the MSMs with defined package of care. That includes also the clinical services. 62% with HIV testing, and 13% with PrEP. And in terms of the comment, it's because of, again, matters of initiation and also erratic supply of the PrEP and HTS commodities. Next. For the people who inject with drugs, again, we have a defined package of care. That is 90% of them were able to be reached with the services. For those who are on MAT, we were able to retain 58% of our clients. And those who are able to be reached with, now among the total population of the people who inject drugs, again, we have a special focus for the female injecting drug users. So 80% of them were also able to be reached with the defined package of care. Again, in terms of now looking at the young people aged between 10 to 24 years, that is our adolescence programming, we were able to reach 45% of the target that we signed against the PF. For the treatment care and support, that is defaulter tracing, we were able to reach 57% of the target. Next. So in general, some of the other programmatic updates that I would like to share with you is there was a revision in terms of what we define as the defined package of care between the NFM2 and NFM3. So for NFM3 is what are the updates that we are getting right now, and that is the period between July and December 2021. So currently, we are looking at those who have been able to be screened for the STIs, and those who have been reached with health education and also change of sexual behavior and condoms, that is for the female sex workers program and MSM programming. Now, for the harm reduction program, we are looking at the needle and syringe program. We are also looking at STI screening, TB screening, health education, condoms as a package. Health education and adolescent sexual and reproductive health risk assessment and counseling on safe behavior for the adolescents, girls, and young people. It's a new component that is being piloted across the 5 counties in the country. So again, PrEP has been of interest in, as a program, and we are looking at how do we then increase the sensitization on PrEP and also engagement of PrEP champions to be able to increase the uptake. Because even looking at the programmatic, the quantitative data that I've just shared, you realize that PrEP uptake has been a bit slow. In terms of shortages of HTS kits, again, it has greatly affected our targets in terms of the uptake, because unless we test, then we cannot be able to actually initiate treatment, and that definitely affects the whole HIV treatment cascade. Condom distribution, again, there were shortages, and still we do have, in terms of access to the condoms by the beneficiaries, an issue that is being discussed at the national program level, that is NASCOP, to see how then can we be able to resolve that. MAT retention, again, issues of transport challenges. Currently, with the incoming of COVID, we were able to actually start what we call mobile MAT dispensing, whereby we now move kind of to specific locations to be able to dispense MAT to our clients at the various hotspots, as opposed to having them walk to our 2 centers, for example, in Nairobi, that is Ngara and Mathare, for the uptake, and Mombasa, we also have a center whereby they dispense MAT. Again, lack of urine toxicology kits affecting the initiation to MAT program. Now, for our adolescents and young people programming, those are the key issues that we are looking at: accelerating of the EBIs and outreaches, that is evidence-based interventions, to reach the targets by at least April this year. Why we are doing this is because we want to maximize on the school holidays. Again, we are looking at the electioneering period, whereby now issues of outreaches is going to be affected, and we wouldn't want to mix the program and politics. So we are trying to work around that to see how best it will work for the betterment of the program. For that indicator that is in bold, is not yet due, that is NSP, the percentage of females aged 15 to 24 who dropped out of school in the last 1 year. And this is an indicator that we are looking at reporting on it come end of this year, because we are now tracking it based on this current grant. Next. So for treatment, care and support and human rights and gender indicators, we are looking at defaulters, and straight from our link facilities, which includes both private and public facilities. So of the people that were line listed at the health facilities and those who were traced back, those are the figures. And this is being done by the community volunteers, and these are mostly the peers. Going to the COVID-19 grant, we are at 20% absorption, and this is because of the delay in terms of receiving the funds from Global Fund. So we've been able to sensitize our various networks, that is for the people living with HIV, for the adolescents and young people, the KP networks, to be able to prepare them to respond to COVID-19, and also to be able to also disseminate the same information to their peers. Again, we were able to do social protection in terms of cash transfer to 2630 beneficiaries in those categories. We have ongoing PPE distribution. Now, currently in this grant, the grant is covering 46 counties, and we are implementing with our 65 contracted partners and other networks or groups within the counties to be able to increase coverage. Next. Yes, in terms of procurement, we've been able to have the WAMBO system in place, and I know in our last meeting we still had issues around the contracting and finalization about the WAMBO system. So items are actually awaiting delivery. I can report on this. And distribution has actually been planned, so that once we get the commodities in, then we can simply be able to roll out in terms of distribution. So for the other PPEs, the sanitizers and reusable masks, for the previous grant, whatever you were awarded, you were able to receive and distributed. Next. Yes, the other important commodities that we procure at PR2 level is the NSP Kit 1 and Kit 2. So again, this is, I can say we have stock in-house that can last us up to end of March for Kit 2 and end of April for Kit 1. So for the Youth Wellness Center, we have one that is operational. The other 4 we've just finalized in terms of renovations and fabrication of the containers, apart from the one that the one in Kisii that we still having structural finishes to be done. So in terms of the prevention centers under NASCOP, the 4 container fabrications done as Mombasa one was non-responsive. Because remember, we were talking to NASCOP and also working closely with the counties to be able to identify which are the areas that they prefer or which are the prevention centers that they will want to be revamped. So for Mombasa one, we still haven't done anything because the county was non-responsive. So we are still vigilant in terms of monitoring COVID-19 in terms of the surges. Next. Yes, so those are the challenges and mitigation measures that we have put in place. So currently we've had a lot of whistleblowing from our partners, and these are the CBOs. For some, we've had to do our background check, and even those who are doing the whistleblowing, even recanting the information. But as a grant, we've had our audit team in place, and we are currently vigilant on such kind of issues. Then inadequate project management budget to support our partners in terms of implementation. So we are actually tracking our savings to be able to support this. Then low rate of target achievement. Again, we are having meetings with our partners and just looking at what are some of the best areas of improvement that we can perform. We can be able to tap on. Again, lack of VL testing. This one I can't overemphasize because it's something that cuts across. Sometimes we are lacking reagents, other times we are lacking so many other things in terms of the VL testing. So you find that up to now, it hasn't really peaked. Some of the hotspots are actually closed and are yet to open. So this affects especially our programs that rely on outreaches. That is the prevention mostly for the AYP programming and KP programming. So again, inadequate funds every first month of the quarter, because unless we have reported to the donor and the donor is satisfied with the reports, then we can't be able to receive funds from Global Fund to be able to disburse to our partners. Thank you.
Wow, thank you very much. So we park the questions for Kenya Red Cross until after the presentation from AMREF. So AMREF, you're next.
My name is Peter Weganjo. I work as a venture development manager with AMREF Health Africa in Kenya. Sustainability is my story, private sector is my story. Project brief. So AMREF is, and correct me if I get those acronyms wrong, we are PR2 on, on HIV, on TB and malaria. So I will present the statistics as they are for 2021 for TB and malaria. So I'll be speaking between the two. So we are PR2, the grant number is there. We work in all the 47 counties. The good thing about this, we do not work alone. We give this money to communities, community-based organizations and other CSOs to implement on our behalf. We have a total of 33, 24 which are community, 4 that are KIC TB. So the engagement process is still ongoing for additional 3, 2 PPM and 1 community-based. The period of the grant is between 2021, July, to 30th June of 2024. The total grant for TB is $107,961,377 million. It is categorized into two. One, the new funding mechanism 3, grant is total is 53 million or thereabout. The COVID-19 resource mobilization is about 54 million. So we've already done the first part, which is the fast track of 12 million to support the government in supplying oxygen to about 332 health facilities in Kenya. Next. Yes, malaria grant, quite small, PR number 2, that's a number. The total funding running through the same period of time is 23,224,000. And that's inclusive as well of about 6 million to support the COVID-19 mechanism, response mechanism. Next. I thought it's important to mention this because these are the people we work with, and these are the people we support in helping us implement. So we just did the selection of the sub-recipients, and these are organizations that are either based in those facilities. So the process is simple. We do a desk review. We open the tender for the 8 counties. Number 3, there's a selection part, and then there's the onboarding part. For malaria grant, we had 11 SRs who underwent the review, and 8 of them were already engaged. I'm not sure whether they sit in KHF, Daktari.
Some do, yes. Some
okay,
do.
good.
Yeah, actually
which is
majority.
Yeah. Next. So in terms of implementation updates, I will not go to the nitty-gritty of the numbers, and I'll just give you the finance updates. So I thought this is a very important slide because then we're dealing with the private sector, and there's a private sector angle for the Global Fund grant, and therefore the PPM mix. So the mapping has been done in all the 47 counties, and the 47 counties have been categorized into two. Category A, 20 counties where we have high burden of TB and account for approximately 80% of the TB cases from private sector with high burden population. And then we have 2 SRs, which is RESOC and NEFAC, covering those number of counties. Category B, we have 28 counties. I'm not sure why there are 48 counties, but the total is 47, so which have low burden of disease. And then we have 21 SRs doing that. So the second column is progress update in terms of the selection, and I had mentioned about that. Next step is finalization of the contractual process with category A SRs to begin the implementation process. Next. Financial update, the exciting part. Yes, the absorptions and so the PR, those are, so in terms of AMREF TB, the budget was about 13 million. We are at 29% absorption rate based on the accumulative expenditure. And that is what has been earmarked for malaria. Against a budget of 3 million, we've spent about 1.3, which represents 44% performance or absorption. Next. For COVID-19 response mechanism, for the activities earmarked under the TB grant, we had earmarked a budget of about 3.34. What has been expended is about 6.9, but we have obligations of 6.9. However, our performance is 22%. And we'll come to the reasons why that is happening. Under HIV malaria, we had a near-marked budget in 2021 of 1.13. Our absorption is 261. We have obligations above 712, representing a 23% performance. Next. Here are the reasons and the challenges why we are doing dismally. First of all, on oxygen, which represents, it was a fast track, and we needed to support health facilities and the government in making sure that we are able to manage the COVID-19 waves that were there. So number one, we had supply of oxygen to the counties comprised of 76% of the total CR19 RM budget. there is a delay, there was a delay, or there is a delay spending this budget due to one, inadequate cylinders from BOC. I think by the time we were doing the procurement, the total cylinders in circulation in this country are about 22,000, which cannot, total in this country, so that cannot match the supply and the waves that we had. And then we have slow rate of ordering from counties due to reduced demand, the up and down, the waves and all that. Counties receive bulk oxygen, do not have oxygen tanks, so those are some of the activities that we have to do. So we have awarded the tender, but no one is consuming the oxygen, the cryogenic oxygen, which is in tanks. Tender for procurement of cylinders was not responsive. However, that is now ongoing, I can confirm, but it should come through. Mitigation, that has been done. We've had meetings with BOC, plus the oxygen tender committee, the oxygen committee, the National Oxygen Committee, and things are being addressed. Number two, delay in reimbursement of TB patients with malnutrition caused by challenges in streamlining the process of cash transfer using TB system. Solution, TB program has planned a meeting to upgrade the TB system. Meanwhile, the activity has resumed. Next. Part of the budget was for the activities to be implemented through the SRs who are engaged in September 2021. The response is that the PR is in the process. We are in the process of finalizing modalities of implementing the CRM19 activities. By the existing SR, the activities will begin in March 2022, which is the month we are. So I think a lot progress has gone. Delay in implementation of RSSH activities that needed extensive consultation with various stakeholders to ensure inclusivity. Accelerated implementation began in January. And finally, delay in implementation of laboratory activities due to prolonged startup process, including development of specifications and discussions with the various stakeholders. These were necessary processes to be done and needed to be concluded before the implementation begins. So specifications for genomic sequencing equipment and reagents have been provided and procurement initiated in Wambo. Procurement of Gene Expert cartridges has commenced and is on course. I think that is my last slide. Thank you.
Beautiful. Thank you very much, Peter. Can we give him a round of applause? And do we have questions for Peter? And before we take questions, I'd like to acknowledge Oduor Otieno. Where is Oduor Otieno? Oduor Otieno is representing us in the TBTRP, Technical Review. Yes, please. He's very actively representing us in TBTRP. And what else? Yes, and RSSH. So you are represented through Oduor Otieno, but I think the malaria TRP, we are not represented as KHF, so Peter, please take that back. And also for Kenya Red Cross, we are still not very strong on HIV. So we need a representative as private sector, KHF in the TRP. But I also from KCM, we'll see how that can be managed. But from as principal recipients, we would like to be as engaged as we are on the TB side. So thank you very much for that. So questions?
Around 7 years ago, we introduced PrEP, pre-exposure prophylaxis. At the same time, we introduced the self-testing kits, and it's around the same time we identified the young population, I think 10 to 24, among almost the key populations, to actually be able to control new infection rates. It's around the same time we were working on 1990. Is it rule on which are being told it was since achieved, and they're approaching 95. So question number one, are we progressing now from from 95? Have we set the target of 100? That's question number one, the progress towards that. And since we've moved from 1990, now we're around 95, and that was set to reduce new infections. So our question number two, how does the new infection rate curve look like? Because if we are improving this way, it means actually the new infections should be reducing. So even the budget should be reducing, because that was the key thing to, at the end of it, or to either remain with the same budget, not keep on increasing, not reducing, sorry, especially for procurement of the commodities. Yeah, those two questions. The trend in the new infection rate, how has it improved over the years as all this money is pumped towards that? And then the other one, I think, what did I ask? And the first one, I think you got that one.
I think this is specific to the HIV program. So, yes, as a country, we are moving towards 95, 95, 95. Though, for those of us who have been following the HIV programming within the country, you realize that not all counties have actually transitioned to 95, 95, 95. We still even have counties who are yet to get to 90, 90, 90. And I'm not able to extract the figures right now, but when you refer to the KENFIA and also look at the CASF2 that is already out, you'll find that we still have increase in the new infections, and mostly among the adolescents and young people, with a major focus on the adolescents, girls, and young people. So that's why right now you'll find that there is a lot of resources that is being channeled towards the adolescents and young people programming. Again, when you look at the fast track cities, again, that is an initiative of the UNAIDS. Again, you'll find there is a really big focus on the adolescents and young people programming. And there's things as simple as just lack of information on how one can contract HIV and AIDS is what is actually eating us as a country. And we've actually, in this current, this NFM3, it was a priority during the grant-making process that we have focused interventions towards adolescents, girls, and young people. When you look at the USAID programming, that's why we are having the DREAMS program. So a replica of the DREAMS program in the USAID programming is what we have under Global Fund as the AGYW programming or AYP programming, which only is being piloted in 5 counties in the country. And that is Kisii, Kilifi, Turkana, Machakos, and Siaya counties. So why am I calling it a pilot? It's because there has been now a serious focus in terms of putting a lot of resources in that area to see how can we wholesomely address issues affecting the youth. And you'll find that when we want to deal with the youth, we cannot go the health way alone. So when you look at the AYP programming, it actually cuts across different sectors. We are bringing on board different players. It's a multi-sectorial approach so that we can be able now to have youth-friendly interventions to be able to address the new infections. So on matters of PrEP and self-testing, unfortunately at grant level, we haven't been kind of given an approval to report on the testing for the self-testing. Like for example, if I was to test positive, I'll still go and follow the traditional HTS testing protocol for me to now have the figures reported. So yes, we have self-test kits on the market. We are having messaging around self-testing, but still we have to follow the traditional HTS protocol for us to be able now to report on the results of those figures. So for me, I'll take it as a challenge because even with the erratic supply of test kits, we'll still get individuals who will probably afford the test kits for those who are getting them through the social platforms or social marketing ventures, or those who will afford to buy them in chemists and do the testing, but still we cannot report on them to the donor. So that is a major gap. Again, when it comes to PrEP commodities, you asked about that. Yes, previously we had strong programs around PrEP, but then these again were funded. But currently, we have issues in terms of uptake of the PrEP itself. Why? Because of lack of information, and again, lack of the test kits. I talked about that. Because remember, PrEP is targeting on the individuals who are negative but sexually active and they are at risk of contracting HIV. Thank you.
I've asked the question and you have actually said where the gaps are. I can give a suggestion on to address the problem. You have identified lack of information on even how to contract HIV among the youth. My suggestion there is that maybe those of us who have children obviously in primary school, secondary school, and who follow what they do, like me, I almost know the entire curriculum of primary school. I can tell you which content is in there. Then, could then Kenya Institute of Curriculum Development be even one of the sub-recipients to make sure this information is heavy in the primary school curriculum? Because there's a lot of HIV, even drug abuse in those contents. I mean, I've read all those books, primary school, secondary school. And the curriculum is so, HIV, it's very well articulated, even drug abuse and all that. So maybe it's not adequate, it needs to be expanded. But instead of focusing it on health, then Ministry of Education, and that's where curriculum development should be maybe some funding or to check out to expand on that, so that by the time someone is even sexually reproductive age of 12 years, they should have all that information, and even is part of the exams they do. It may improve on that instead of just maybe at AMREF or Red Cross, you're just going to the community to look at those, to look for those girls there when they are already even engaging in, and the boys obvious, in sexual activity. It could start down there in the curriculum, and by funding the Ministry of Education, we might get better impact.
Thank you, Daktari, for those recommendations. Under NAC, we are partnering with NAC and KICD, that is the Kenya Institute of Curriculum Development, to be able to rework on the life skills program that is currently in schools, to see how can we have age-specific or age-appropriate information sharing when it comes to the adolescents and young people. Again, I talked about a comprehensive AYP programming. I talked about EBIs in my presentation. Under EBIs, we have very age-specific information sharing. We have interventions like Health Choices for a Better Future, which targets ages between 10 to 12 years. We have Families Matters, which actually targets the parents of the preteen, so that as a parent, as your child is approaching teenage, how are you able to talk to the kid, and so that the kid can be able to open up, and you now start talking to them about sexual matters as in the process, then you can be able also to talk to them about the risk measures that are associated with HIV. So it's a very comprehensive program. Thank you.
Stacia, what do you want me to say?
We have a new strategic plan. We want them to, validate.
Good afternoon, members, guests, and friends. As you've been informed, my name is Gakombe. I am the chair of KHF. We've been busy working for you as our esteemed members. In some areas, we've been successful. In others, it's still work in progress. As many of you well know, change, especially where government is concerned, is a slow, laborious process. But there is no alternative to that process, so we are engaged with a long-term view. Among the key areas that we are spending time, energy, and effort on is healthcare financing, especially in the immediate, the question of contracting with the NHIF, because for providers, and I happen to be one, we consider the contracts an essential threat, because if the rates that we get are not economic, and we are not allowed to co-charge, or ask patients to co-pay, that means the providers won't have enough money, and that means our suppliers won't have enough money, and that means the manufacturers won't have enough money, and the technology providers that we work with, and basically the entire pyramid collapses. So we are working very hard in many places, overt and covert, to ensure that the rates we get are economic and they'll enable many more people to access healthcare, and the sector will continue to grow. The second area of engagement, and in no particular order, the first one, that is our number one priority, is ICT. As many of you may know, I'm very committed to making ICT work for us, because I see its great integrative capacity to make us a far much more efficient and effective sector that does not waste the resources that the people of Kenya have for healthcare. So whether it is telehealth or systems such as those provided by Smart and Savannah to connect us, or platforms such as the one Vinod provides in supply chain, all these tools are the oil that will make the engine that is our sector run much, much better. On housekeeping matters, we've been working on a strategic plan, and we made tremendous progress, and I'll leave that to our CEO to cover, because some time back we are taken for a seminar, and we were told that directors should not be interfering busybodies. We should keep a keen eye on what is happening, but keep our hands off, so that our CEO and her team can run an efficient and effective operation. I'm a CEO myself, and I do not take too kindly to my board. Fortunately, I've had a very good board for the last 27 years. I really have no complaint, but I don't take kindly to board members who decide that they have nothing better to do than become managers in the organization. So I'm trying to make sure that the treatment I get from my very good board is extended by myself and my core directors to our secretariat, so that what we spend our time doing is trying to help the secretariat fill the gaps they may have without being in the way of progress. And that is how we believe we'll achieve far, far much better results for all of us. So without further ado, I am just one among a team of equals, and each of them has an important role to play, and mine is to be what I have just been, the figurehead that makes opening remarks and then goes back to sit and drink water as the rest of the team tells you the real stuff that we've been up to. So back to you, Nyalita. Thank you all for coming. It is indeed great that we can meet in person. We must, all of us, celebrate the fact that we are part of the team that has helped this country get COVID to the levels where it is now, so that we can all engage and have a meal together and share this in-person engagement as the rest of Kenyans do the same. And we need to continue to be at the forefront in encouraging our people to keep COVID where it is now and to prepare the country for the next inevitable pandemic. Asanteni sana. Have a great afternoon.
Thank you, Chair, and thank you for the kind words and all the support. And I would, at this time, just request the board members who are here so that the members can get to know, the men and women behind the chair. So if you could just kindly quickly introduce yourselves so that at least the members can know who to reach out to in case they have anything they'd like to, suggest, clarify, and so on and so forth. So We start with, we have apologies from the Vice Chair. Dr. Linus?
My name is Dr. Linus Ndegwa. I'm a director at KHF and the immediate past president of the Kenya Dental Association.
My name is Vinod Guptan. I'm one of the directors at Kenya Healthcare Federation. I also double up as the chair of the supply chain committee, and I also am the board lead at the PPP, the Public-Private Partnership Committee as well. Apart from that, I'm the vice chairman of Kenya Association of Pharmaceutical Industry.
My name is Francis Karanja. I'm a KHF director. I'm also a director, should I say, committee person at CAPI, which is Kenya Association of Pharmaceutical Industry, and I work at GSK. Thank you.
Thank you, Francis. Is there anyone else in the house that we may have left? So we have, you saw Dr. Daniela. She's representing the Pharmaceutical Society of Kenya at PSK and hence at the board. And we also have Dr. Elizabeth Walla, who is a vice chair. She is seconded from Ponea Health. And yeah, so that's the team behind, who is supporting the secretariat. They're doing a wonderful job, as you can see, and we really appreciate that you know, your presence here and turning out in large numbers. Really, we appreciate that very much. I also want to take the opportunity also to acknowledge members who have joined us since the beginning of the year, starting from our very own Metropolitan Hospital. So they joined, previously they were in KHF and Kenya Association of Hospitals, which is one of the member institutional associations, but deliberately now on their own capacity as an institution. Then we have HealthX. HealthX is very unique. They joined and they wanted to showcase the solutions that they have. So at the back we have, and if you looked at our poster, there was an opportunity for members to showcase the services that they have. So I don't know if we have a representative from within here from HealthX who can just stand up and to be acknowledged. HealthX, yes. Karibu sana. So make sure that we will, and I hope we've had an opportunity to interact with your team behind there. Then we have, is it Viebeg or Viebeg Medical? Do we have somebody from Viebeg Medical? Okay, all right. And then we have Integral Health, led by John Juma. Is John in the house? And yes, John, please stand up. That's one of the new entrants. Then we have Kenya Association of Opticians. Kenya Association of Opticians. Anyone in the house? I hope our secretariat takes note because maybe they did not receive the communication. Very important. Then we have Kenya Women and Children's Wellness Center. Do we have someone from KWCWC? Okay, we don't have that. Again, please make sure the communication from our new members is in place, and please let them know they can send an alternative. So the person behind KWCWC is Faith Muigai. She's the executive director. She's an immediate past director of Kenya Healthcare Federation. Then ChemLabs Limited. Do you have someone from ChemLabs? Very good. Karibuni sana, and I hope today was a good opportunity for you. We have another event coming up on the 7th of July, of April, which is the CEO's platform. A platform that the directors realize an opportunity for the leaders in the health sector to come and have a tete-a-tete or a dialogue among themselves and network and so on and so forth, which we thought it was a brilliant idea. So we've sent out the invitations, but immediately after this, we will also be sending the invitations very aggressively for the top leader of the organization and an alternate. So if the top leader is not available, please make sure your alternate is available as well. We don't have a chief guest yet, but I know we will get a good chief guest. Yeah? All right. So my next task is just to take you through the strategic plan. But before I take you through the strategic plan, I just want to remind you who we are so that we know the moral authority that we carry. So we are the Health Sector Board of KEPSA. KEPSA is the apex body of private sector in Kenya, and it basically is structured in sector boards. And the sector boards mirror the government ministries. So we have health sector board, we have a tourism sector board, we have trade and industry, and so on and so forth. So we are the health sector board of KEPSA. Now, most of the sector boards are still technical working groups within KEPSA, but as Kenya Healthcare Federation and a few others like tourism and ASNET, agriculture, we have registered ourselves as a company limited by guarantee, of course with membership, and so that's who we are. So we are the private health sector voice in Kenya, and we have that moral authority and mandate. We do plug a lot and very actively, and we inform the health agenda at the KEPSA, but also, which essentially informs the country health agenda. Of course, we have a lot of deliberations and collaborations with the Ministry of Health, the state agencies, the Treasury, but of course, KEPSA comes in to put in a lot of force or a lot of, to amplify the voice, because of course their voice is bigger than ours. But our technical expertise is what we feed in to make sure that the health agenda is in favor of the private health sector. Yeah, and when we say private health sector, for us, it's your health institutions, associations, your corporate, NGO, and social enterprises, and your professional associations as well. So really, we are looking at, and it's part of our mandate for the new, strategic plan to actually now really become a force to reckon with, to really shape the private health sector. So one of the things that has come up also is we were challenged, and we have actually revised our mission, vision, and core values. So you will see a lot of new branding, new stuff, but basically we're looking more futuristic. So our vision has been revised. And again, we can take this as a validation, so give us feedback as well before we finally, roll it out. So we're looking at, our vision is to be the leading membership organization advocating and supporting health in Kenya. And our mission is to champion the interest of our stakeholders through transformational advocacy and support. Yeah, transformational advocacy and support. And our core values are accountability, collaboration, innovation, and agility. Of course, just to remind you that we were founded in 2004, we were registered in 2008. In between, there was a lot of due diligence being done by the government, and we've been in existence since then. And I think we've achieved, we've achieved quite a lot, but I think we've just only scratched the surface. So we know we organized in 6 thematic areas, which mirror the WHO's health systems. And it's, again, that is what informs our technical working groups or the technical committees. And you will meet the technical committee leads before, as part of the last session today, because they are going to take us through what is it that they've been doing. And I really urge each one of you to make sure that you're represented in each and every of these committees, because some of the issues are cross-cutting, you don't know what is being done. For example, the NHIF topic, yes, it's healthcare financing, but at the same time, it's about policy. So a lot of cross-cutting issues. This is your board and your secretariat. Yeah, just how we engage at all levels of government. And also, we also engage a lot at private development partners. Of course, we also collaborate a lot with our members as well, as you may be aware on some of the projects that we have done in the past. Of course, our liaisons, both at country level, at regional level, and from a development partners perspective, what I can tell you for a fact is the fact that the development partners are now paying a keen attention to Kenya Healthcare Federation. Because of course, as you know, the journey to self-reliance involves having the private sector on board, which is a good thing for us. Of course, opportunities for strengthening the regional coordination. East African Healthcare Federation we are a founding member. They will be having a conference towards the end of the year, but we continue also to have board meetings just to discuss the issues. We've just actually concluded a regional project between the East African Healthcare Federation, which is Bill and Melinda Gates. It was a Bill and Melinda Gates funded through Africa Economic Research Consortium, and KHF was the lead implementer. And at that time, Rose she was an intern, so she's one who led that project very well. So just to tell you the opportunities, and also, Kenya being a hub, we provide you a platform also to give you linkages as you expand in the region and also in the continent. So that's an opportunity and a value proposition we give to our members. Here you are. We currently have the highest number of members ever. So we've just hit 180, and we are growing, a lot of interest. But from a strategic perspective, now we're actually even going to do it a lot more. So we will probably be hitting maybe 500 plus. It's not in the numbers, just to make sure that you don't struggle out there alone. You belong to an organization that can actually amplify your voice. And I think that is very important, because you've seen what has happened. For example, these organizations that have been suffering with the KRA. When you look deeper, they didn't belong to any organization. But essentially they belonged, and they were able to have a favorable outcome at the end of it. We're not promising anything, but we're saying we can actually help by it. One of the things that we didn't know, and this was brought up by Dr. Maneki, thanks for that, is that Resolution Health, I didn't know as a secretariat that we had issues. It's not that we can resolve anything, but it's that what can we do as a general membership in health with a stake, because it's affecting everybody. What can we do at the regulators? What voice can we take to the Ministry of Health? What can we do to the affected parties? Because it's everybody across the board. Because if it's affecting the hospital, it's affecting the supply chain as well, and the consultants, etc. So those are the kind of things we are saying. We come together to actually find win-win solutions for such situations, may they befall you, but also the good stuff, for things that we want implemented. So the importance of belonging. So anyone in health, feel free to urge them to join us. What we are known for, or what we do, our main thing is advocacy. We provide opportunities for networking. The CEOs will have an opportunity on 7th of April also to really be closer to the board and tell them what are the things they'd like to see differently, what are the things that would like us to focus, what are the things they'd like us to stop, etc. Yeah? And then engagements, projects, and regional integration. If you don't see a logo there, then it means you're not paid up in 2022 or you're a newcomer, so don't worry about that. But we're urging all our members, by the way, if you have not paid, the deadline is next week, Thursday. Tafadhali pay so that at least we can be sustainable from an operational perspective, at least to meet the basic operational costs like salaries and so on and so forth. So, so that's so in terms of impact, it's across the board: policy, regulation, advocacy, regional integration, and public-private dialogue. By the way, from a regional integration, at the end of May, we will be having a Expo, East African Health Expo, which is to be co-hosted by KHF, Strathmore, and the UN SDG Partnership Platform. It is happening, and it is moving in speed. It is the next thing that we'll start now, communicating starting tomorrow latest. A lot of opportunity for those who have also regional interests, and give us feedback as soon as you see our publication here. But also public-private dialogue is very critical, because we are not, our moral authority is not to go to the streets and raise flags or banners, but it's to really have a dialogue because you only get solutions from people who you can dialogue with, and you come up with a win-win situation. So it's not an issue of my way or the highway, but you meet in between. So let me go back to the strategic plan. And on the strategic plan, so basically the Kenya Healthcare Federation has now developed a new strategic plan for the period 2022 to 2026 with two main factors in mind. One is on the leadership, the other one is on growth. So in terms of leadership, the directors has given directions to the management to review the previous strategic plan, which we did together with a consultant, objectives and performance management measures to ensure that they align to the vision and mission of the organization. In terms of growth, is the need to establish a high extent of achievement of the goals and objectives of the previous strategic plan and identify the performance gaps and key lessons learned by the organization. So after reviewing and sitting with the consultant, so we reviewed our mission and vision and our core values. It was a very open and candid discussions. We were really challenged. And I can tell you that by the time we came out of there, we were like, wow. Yeah, so that for us was an important one. So in terms of, so we reviewed what we've done in the past, come up with a new strategic plan. We've come up with new vision and mission. But what we must remember is to maintain 4 thematic key resource areas on which to focus on. I can tell you in the previous strategic plan, which remained in draft for forever. It was never implemented, but we still implemented a good portion of it. It had 7 strategic pillars. You can imagine, you don't know where to focus. But now we are very, very, very focused, yeah, with very key deliverables behind each of them. So the first one is financial sustainability to increase resource mobilization and operational excellence. And I like the word operational excellence because that is what will take us extremely very, very far, and also will give us the credibility and the image that we would like, that we duly deserve, let me say that. And then stakeholder management, enhance staff satisfaction, corporate governance, and advocacy. And these things include mapping out who are your stakeholders, right from in-house, outside our members, etc. And then strengthening the institutional capacity, increase stakeholder satisfaction and strategic communication. You are part of you are the main stakeholder, you are main stakeholders of the organization, so we need to make sure that what we're doing is in line with what you desire. Yeah, and then also now strategic partnerships, attract, engage strategic partnerships. Just short and sweet. But it has a lot of stuff behind it, yeah? Okay, so these are the 7 focus areas of last strategic plan, which remained on draft. I repeat again for the nth time, because the board was very mesmerized that we didn't quite whatever, but I must say we did quite a lot with the resources that we had. And then, from a secretariat's perspective, there are learnings that we take forward on how we should do things. But more important, when there are so many activities, tracking the implementation becomes a problem. Yeah, we did do a situation analysis and environmental gap analysis scan, just to allow comprehensive and detailed documentation of the process and outcomes. We will share this document for you to really internalize it and look at it and give us feedback before we finally finalize. And then we also conducted a SWOT analysis to determine our position in the health industry. And you will see from this that we really have a huge potential. We have a very huge potential that is not tapped. And that is a good place to be. But of course, the challenge is that, how do you ensure that you structure yourself, you resource yourself to achieve that? So that's very critical. We also mapped out key stakeholders that will be engaged during the next phase of a strategy. So you will see we have, of course, the public. And I think one of the people that we need to bring on board will be your patient groups, for example, but also the general public. When good stuff happens, we need to, also communicate as much as when, challenging situations happen. We have to be out there at the forefront as the health sector lead, giving our perspective, our strategic position papers, policy papers, and so that's one area that we must be to be seen as the the health sector opinion leader. That's very important. Also, the development partners, I've mentioned that the county government. For those of you who are in the development world, there's an offer that has been issued by USAID on a local development organization or something. It's about not staying, not having just umbrella organizations at the top, but also how do you develop structures at the county levels to better engage. So that's an opportunity for us. But for us as KHF is how do we have very good structures and PPDs, public-private dialogues, between at the national level. How do we cascade that down, either from a regional economic blocks, as the counties are, or even down. The good thing, again, is that we have very good relationships with the COG at all levels, and now it's an opportunity for us to really get engaged at that level. And also to make sure that, people don't feel that we're just in Nairobi and as a national. Even the private sector person playing in any of the counties has a voice, either at the county level and, cascaded upwards to the national level. The hows are things that we can think about and wherever that, and see how to. And then, of course, the government, ministry, then we have the agencies, we have the regulators, we have the Ministry of Health, the people we are so used to engaging. Then we have those members, employees, banks, insurance companies, training and research institutions, very important for innovation, parliament, and media. So media and parliament, we have been very weak over the first couple of years. But again, you can see we are starting to walk that journey. Yeah. We have already anticipated some risks we might face as an organization in the strategy implementation and developed some mitigation measures. So some of the risks would be cybersecurity, your usual corporate risks, I guess. Yeah. Operational risk, social license to operate, organizational resources, and of course, legal risks. And then we have to be very strong in our monitoring and evaluation. I think this is somewhere also which has not been quite existent in our operations, but now from a strategic perspective, we are focusing on it. Yeah. So that's it on the strategic plan. Maybe we can, I don't know if you want to take questions now, or we go to the main presentation, and then we can take questions at the end. Okay, let's go to the main presentation. Okay, members meeting. So that is done. So those are our new members. It's always nice to see the logos, because that is your identity, corporate identity. So you have Metropolitan, HealthX, Vierberg, I think, medical. I need to be. Then there's, how do you pronounce? Manion Daniels, yes, Manion Daniels. Then there's Integral. Then there is the Kenya Association of Opticians. And then there's Kenya Women and Children's Wholesale Center. And then there's Chemilabs. I think we saw those who are present here today. In terms of advocacy, Chair, you'll allow me to take this one for you. Yeah, so we've actually, like the chair said, we've been overly engaged over the last, and I think NHIF has taken a lot of energy, but thanks to a lot of you who came in to step in and represent KHF. In fact, as we are sitting here, there's a lot on the other side, led by Dr. Walter Obita, who is the director of KHF, who are actually, so we have, I think we have someone from Penda, Maura, then we have Dr. Gitao, she's also in that team. We have someone from the Secretariat, Nelly. So really, and tomorrow there's something else happening. And today there are 2 sessions, one in KCC, one at the NHIF boardroom. And tomorrow is another one, half day. If we don't engage, my friends, you know what happens, and it has happened before, but you know what is at risk in this time. But I can guarantee you there's also a silent technical working group that is working out the nitty-gritties. But more important that we are prepared in all fronts, but let's see what comes out. The best we can do is to really stay engaged, yeah? So KEMSA, led by the director responsible for supply chain, Vinod, we had a meeting in January with the KEMSA acting CEO, Mr. Kabuchi, and issues, and also present was Universal. So some of the issues that raised here also were raised there, but I think the issues that were presented by Mr. Palu for Universal Corporation are very strategic, and that's something also we need to take up as a supply chain and take it further, especially on the tax zero rating for raw materials in favor of and the other levies, yeah? Then UHC National Scale-Up and Health Workforce Conference. We were very well represented by all our members. The official representative was Dr. Sitonik, who is the chair of the Human Resources for Health Committee, and she did give us a very strong report, but I want to thank each and every one of you that participated. At least chair's presence was felt and appreciated. And also, we also attended the UHC National Scale-Up, last-minute invitation, but sometimes sometimes you just have to show up. Otherwise, then you'll be forgotten forever. So I represented KHF together with Dr. Anne Musuva, who is the chair of the PPP committee. And yeah, I think that we were 2 of us. And there were a couple of other invited KHF members as well. We had also have a breakfast meeting with the CEO of NHIF and his team. And we got a lot of insights, and also were able to really candidly share everything. But of course, every coin has 2 sides, so we were able to have a common understanding of the 2 sides. And that actually also informed a lot of the input that we provided in the memorandum for the various rules and guidelines, but we still continue to engage. Then MOH National Stakeholders Consultative Workshop on the National Adolescent and Young People Reproductive Health Policy Development. Again, another last-minute invitation. One day I hope this will cease. But luckily we have a very strong staff team now that is able to handle this technical stuff, So they're able to represent KHF ably in technical meetings. So in this one, we were represented by Nelly, who is also now representing us from the Secretariat at the NHIF meeting in NHIF boardroom happening now. So you see, I think it's a good direction we're taking, because then it doesn't have to be, people are very busy, but if you can build the capacity within the organization, I think that is more permanent, yeah? And so what we do is that within the committees, the committee leads will represent, but also we have someone from the Secretariat to support them. It always helps if this person can comprehend the technical nature of what is discussed there. So this is the direction we're taking. And just to let you know, of course, we are hoping to get a secondment from the United Nations volunteer program. So hopefully before end of June, this will come through. It's been slow, but I was told it's coming. So again, just to really enforce and have a strong secretariat in whichever innovative way we can. When we can't afford it, we ask for support. And I must thank Africa Resource Center. I don't know if they're represented here. Last year, for about 6 months or so, they seconded someone to Kenya Healthcare Federation. And that person was able to run with one of the programs which has just ended, the multi-stakeholder forum. So it's a call out to all of you. If you feel you can second somebody to come and support the Secretariat, we really appreciate that. And then USID and Palladium Group International, new partnership initiative. It's called Expand Partner Co-Creation Workshop, again represented by Dr. Sylvia Mwelu. Again, you can only be in so many meetings, so I think the fact that you have technical persons that can represent you when you're called to show up, that's been very valuable. But in the process, you also learn a lot of how things are done, so that in the event that you're running your own program, then you also have teams that can run with it. Then last week, on Wednesday, we had our first quarterly ministerial stakeholder forum for the year. This was, typically, the MSFs are co-chaired by chair of KHF and the CS Health. But you can imagine it's been a busy time with COVID and all, so usually he will delegate. So this one was chaired by Kas Mwangangi. Very good deliberations, very good outcomes, very good discussions therein. Good thing is that it's heavily represented by the board and the committee chairs, and we're able to present the issues. And you'll see what we presented to Kas Mwangangi, but also some of the things that some of the things that will follow through, some of the things that we need to do to be able to achieve, to gain traction, so to speak. At this point, I will ask the committee leads to come and make their presentation. Shucks. So these are your committee leaders. So we have Njoki is chairing the Health Financing Committee, Millicent, the Health Regulations, Quality and Standards Committee. Then we have Dr. Ann Musuva is Partnerships, Communication and Resource Mobilization Committee. She is represented today by her deputy, so Mr. John will do the presentation. Then Toroti under ICT and Mobile Health, Dr. Joyce Sitonik, Human Resources for Health, and Vinod Guptan, Supply Chain. So let's see which one goes first. Health financing. Do you have anyone from health financing? I think they're busy on the other side, so I'll just quickly take you through this. So basically, this is what we presented at the MSF. And important for you to participate in as many committees as you can manage. You have a representative in the committees, so that we tease out the issues that come out from the committees and take them to the board, who takes them to the Ministerial Stakeholder Forum. And for every committee, there is a board champion. Like this one is Walter, Dr. Walter Obita, who is in that meeting. So very important that you participate in these committees. Appoint as many people as you can. There's no limit. One of the issues that will go in here, but we'll appoint a special committee because that's an emerging issue, is the issue of resolution health. What can be done about it so that the pain is not painful? It's not too painful. We find a solution to turn around that situation. Yeah. So you can see the NHIF members are facing the lack of neutral English. So jury and, NHIF is the jury and the judge. So basically we told MOH, and we're going to follow up with a written document that says that, and the good thing is that when you speak to other quarters like Parliament, they say that's something they're also keen on. You cannot be collecting the money, you cannot be the one deciding who to pay, and onboarding who to pay and when to pay and so on and so forth. There has to be separation of duties. That's very critical for us. We're saying appoint an independent organization that will be also, if they're aggrieved on either side, you can run to. And then delayed payments owed to private health facilities. Please, I think we've only received 2 so far. NHIF told us the historical payments of 17, 18, they're working on them to resolve that because there were technology issues. So we know that a lot of your money is tied in there. Unfortunately, they said they ended up paying some facility twice. We don't know. But what they told us is that we're going to give you a template for your members to fill, and you submit. And they submit one by one. So we have received 2 so far. Please, if you're owed money by NHIF, even if it's the one which is locked up, fill those 2 templates. One is for outpatient, one is for inpatient. Send it to us. When we send it to NHIF, we will have you on copy. So please do that as soon as, if you can, by tomorrow, but we'll leave it open. It's just a matter of the urgency on your side. That's very important. Then we have delay in issuing new contracts and delayed onboarding of accreditation of services to existing health facilities and NHIF contracts. I think those discussions are ongoing. And we hope by start of July, things will be moving. The agreement is that for new services, they will be onboarded as they happen. They're not going to wait for the renewal of the contract. Payments, currently they promise that they're paying within the agreed contractual terms at worst, yeah? Apart from those special cases. So if there's any deviation to that, please let us know so that we can also have a dialogue with them and see how they can help you. But also on our side, we make sure that our documentation is very complete, so to speak. Reimbursement rates for specialized care, that's an ongoing discussion. It's also the discussion they're having in NHIF boardroom now. So the chair, our KCF chair is spearheading that discussion. And I think we are fully engaged and we are fully alert. I think that's what I can say. The outcome, we'll see what comes at the end of it. Then operationalization of NHIF Amendment Act. These are the draft regulations, which, as I said earlier, we have submitted our memoranda on each of them. And also, it's what they're discussing at KICC today. It's what we discussed. It's also been part of the discussions with NHIF in the boardroom, I think, today, last week as well. And tomorrow also there's a meeting on the benefits package. Sometimes they limit how many people can attend. So when we send a call out, please respond as soon as possible. Sometimes we might not do a call out because Dr. Obita, Joki, and the lead in the healthcare financing, even within the healthcare financing committee, we already have representatives. Yeah. So don't worry when you feel you're not engaged. Supply chain.
Thank you, Anna. Good afternoon, everyone. So once again, my name is Vinod Guptan, and I stand here as the chair of the supply chain. So director I've left behind there. So there are a few main areas that we have handled over the past 3 months. The three being policy, commercial, and business. So under the policy, we have already had quite a number of discussions into how can we better the current working environment and get more business done, while ensuring that structures and regulations are strictly followed. So by saying that, I want to take you or draw your attention to the fact that there are quite a number of regulations may be known to you or maybe not known to you that are happening on the background, and we are in full view of all that. I have a very good team with me, though it's a small team, but we work with full heart, and hence we are also discussing almost 16 regulations in the pharmaceutical side. And day in and day out, together with the CAPI team, we are coming up with position papers, and including the changes of clauses that we may want with the current existing regulations that we have. I'm not reading from there, you can watch, but I'm saying what we are doing as well, but it's all mentioned there in a lot of words. So we are also working towards getting single regulator. By that I mean there's KMLTTB, there's KEBS, there's a dairy board for certain range of products, there's cosmetics, there's PPB. So if the KFDA comes in place, which has now gone into 17 readings, and we are back to reading number 3. So we have started all over again. So with the current state of scenario, I'm not sure, and we don't know whether we would get the KFDA up and running before the new government comes in. All said and done, we are not losing track of it. So on the second reading, we found that what we were reading was the 4th reading of that 17 reading that we did. So imagine where we are now. So it's all gone for a toss. So every time we find clauses that were taken off are being brought in again, unfortunately. So we need to have a very keen eye. So all those who have are privy or have access to the readings or the documents that come out, please point out where we may have missed out. But I can assure you, we will not miss out. So on the commercial side, well, you saw some good photographs. Yes, we didn't go there to take photographs. We did a lot of work. So suppliers have been paid. And by paid, I mean they have been paid. There are a few suppliers that were not paid by KEMSA. We are following through. Few reasons beyond both the supplier and KEMSA. We're also trying to see how we can mitigate the financial flow of from the treasury into KEMSA, though it's not within any of our forte to handle it. But yes, we have a bureaucratic process in place, and we are trying to ensure that as the suppliers continue upping the fill rate. Right now, the KEMSA fill rate is at 12, maybe 18%. Unfortunately, so it's a sad story for our country. So we should get between 80 and 90, maybe if not 100%, 80, 90% fill rate. I can assure you, none of the suppliers are saying that, no, we are not ready. They are all ready. It's just that they are saying, can we be paid for what we supplied? And hence the reason for the low fill rate at KEMSA. Knowing fully well that patients still continue to suffer. So this is what we're trying to mitigate. As we do business, how can we ensure that our patients do not suffer in the cause of we doing business? So that's on the commercial side of it. We are also trying to see, yes, Universal Corporation, local manufacturers, FKPM. We are trying to ensure that how can we now try and get zero rating, not only, tax-free importation processes taken up for the raw materials that come into the country, for the pharmaceutical finished product packaging material that come into the country, so that the cost burden is not on the patient. So as the government continues to collect revenues from all these packaging material that comes in for pharmaceuticals, we will try and see how best we can try and put different HS code for the packaging materials that come specifically for pharmaceutical products. So we will get there. We are not there yet, but we will get there. It's a battle, and we have a few soldiers, we have a few commandos as well, but I'm sure we will win this battle eventually at one point. Okay, on the business environment, we have tried to have very regular meetings, and like I said, I have a small team, but there's a whole list of 67 people that are on my committee, are supposed to be on my committee. I normally have 11 or 14. The last time I had 16. So I would ask for each one that is willing to be part of the committee and willing to be part of the vibrant team and get into action, roll up your trousers, roll up your sleeves, and get into action. This is the team to work for, or to be with. We have a work plan in place already, and following from the strategic plan, the work plan is ideally aligned, and this is a new strategic plan we have put in place, but we already have the work plan that is aligned with the strategic plan. A few tweaks that we need to get here and there, but yes, all in all, we are a good-to-go team and very vibrant, like I said before. So that's it, yes. Again, you saw good photographs, Ministerial Stakeholder Forum. So it's not photograph, it was a lot of heated debate, a lot of emotional outburst of what we are facing as an industry, of what we are specifically facing in terms of supply chain. KEMSA was present, NHIF was not present, but KEMSA was present on the table. So he took back a lot of messages from us of how can they better what they want us to do better for them. So we are here to better as the industry for the industry. So that's it from me. Thank you. I will look forward to questions, remarks. None? Thank you.
Thank you, Vinod. HRH? Anyone in the house? I know Dr. Gitao joined the NHIF team. She was supposed to do this for Dr. Setonik, but they have not finished yet, so not to worry. So in terms of the Health Workforce Conference, for us the message of the Ministry of Health, I think it was a beautiful conference that was well attended and well organized. And this is the feedback we got from Dr. Sitonik on participating. So that is that was a message we took back to the MOH. Then we have KHF engagement with the Kenya Health Human Resource Advisory Council. It's a very active council, and I think it may remain, I hope it remains very active. They've actively been reaching out to Kenya Healthcare Federation. Dr. Sitonik and Dr. Gitao have been representing us in all the sessions. They're actually also trainers of, I think, the National Health, I think the National Workload Indication Staffing needs something like that, but we are fully engaged on this. So what our ask was the integration of health workforce IMS, which encompasses both public, private, and also FBOs, NGOs, and other health services at national and county level, so we know who is where at any one time. And then with that respect, so there's a national workload indication staffing needs. I think it's currently, they've sent out a survey for that. And then there's a legal framework for HRH data sharing. We have this framework, and we have forwarded it to the KEPSA legal team to give us feedback. I know it's not moving very fast, but we will push to make sure we get at least the feedback to the to the KHH RSC as soon as possible. Then the National Health Workforce Account based on human resources for health data. So this exercise will be taking place after the legal framework is approved. Then the other thing was strengthening of HRH capacity, strengthen cadre recognition, schemes of service, scope of service for emerging and existing roles, and need to expand facilities that can host interns to increase HRH capacity. And then in terms of what we're proposing, we are saying private sector is ready to partner with MOH in curricular development and training and placement of HRH, and I know we are. Some of our institutions are already hosting interns. And then HRH management and retention in terms of HRH governance, strengthen cadre recognition, schemes of service and scope of service for emerging and existing roles. We had the multi-stakeholder partnership program that has just ended. It was focusing on the emergency medical technicians, community health workers and volunteers, and information, health records and information officers. But of course, you've also seen, there is now recognition of the morticians and so on and so forth, just also to make sure that we know who is where and, what is their scope of practice. Then updates on HRH exchange in Europe for work placement and value proposition for Kenya, and HRH data sharing framework. So we asked the ministry for progress on the document and implementation plan to be clarified. And basically, we were informed that the challenge is always that you cannot stop training when you cannot absorb everyone. But yet there's a country in another country, there's a need elsewhere. So you might as well just continue training rather than just say you cannot train because you cannot employ. And you cannot employ because you cannot absorb maybe because of resources, we don't know. So that's something, because our question was, why are you sending our nurses to the UK? You have a framework agreement, and yet we need them here. So it's one of those things that we had an interesting discussion. Odwar? Millicent, you're here.
Good afternoon. My name is Millicent Olulo. I'm the Regional Director for Advocacy and Partnership at Farm Access, and I also chair this committee on health regulations, quality and standards. I will not actually repeat what has been alluded by the other, my colleague Vinod, a lot of work on regulations, also in terms of health financing. As you heard the chair was saying, most of these things are actually cross-cutting. So it's important that we recognize that. But one of the things that I want to share is very positive is that even as we've been engaging with the ministry and the government is that they're adopting some of these things that we are bringing on board. An example is the COVID-19 emergency preparedness measures and vaccination. We were able to share that, and all our inputs were actually incorporated. So that is very positive feedback, that they are also incorporating what we are giving. And in the recent, late in December, I believe there was also a maternal, newborn, and neonatal bill which came up, and the members met, we interrogated and looked at what exactly does it entail, and we agreed that this was not timely. Again, the ministry was able to take that very positively and take our position as the private sector. So I'll also just allude to some of the issues that have been coming up from the members of KHF and from the providers, is the issue of licensing and the fees that are being proposed by the boards and the regulators. That we are also working in very closely, and I know we have some facilities that have raised this concern, like tomorrow we'll be meeting the laboratory board to actually discuss and see how do we reduce the burden for the providers and avoid the fragmentation across the boards and councils. So in a nutshell, that's it. We are also involved in the NHIF work that we look at what are the issues of service delivery, quality and standards. So it's not only about the cover, but it's also about the quality of care. Because when people start paying, they want to see value for money. Thank you. Any questions? If not, over to ICT committee.
So in terms of the ICT, the Ministry of Health, KHF, has been heavily engaged in the development of the draft EH bill at a national level. At some point in 2 weeks ago, or thereabouts, we were surprised with the county health bill, which we actually made our own submission, and thanks to CarePay, they were able also to really give a quick turnaround on the feedback, also having been involved in the development of the national e-health bill. But basically we are saying merge the two, just have one, the national e-health bill. So that seems to be also the thinking of the ministry, and we believe that we will only have one e-health bill. For those of you who have not seen the draft e-health bill, just write to the Secretariat, we will provide you with a draft. Then there was a dashboard on national COVID-19 response capacity building that was sponsored by, which was led by the Ministry of Health. They invited KHF among other stakeholders, and CHAI was a sponsor. That has been developed, but because, of course, of the current low offtake, we're looking at what can we do with that dashboard now, and I think there are very good ideas around it. Yeah, so it's basically, but more important for us is the private sector-led dashboard. I think it's in the next page. No. So we are developing, and we, together with Smart Application, we're also developing a dashboard for data exchange and, the important critical aspects between our facilities who are members of KHF and outside. We have sent out the call for information. We have not received anything, but now we will call the relevant facilities one by one, just so that we explain the need, so that they can support us to build this platform or dashboard that will be KHF-led. Then private sector facility data integration with MOH systems. So there's a pilot that is almost complete, where at the end of the day, it aims to get rid of all the manual data entry, those big books, so that data, especially on the immunization part, and more so COVID-19, but also the other immunization. So again, so we have, our chair has volunteered his facility, and that is almost, I think in another 2 weeks, the pilot should be complete, and then we'll scale it up to the other facilities who would be willing and to actually get rid of their paperwork, those vaccination booklets among, manual records. So the data is automatically sent to the MOH database. So you don't need to have the paperwork done. So I think that is quite transformational. As soon as that is done, we will we will launch it, and also now start inviting, it's for everybody, public sector, faith-based, and private sector facilities that do vaccination. And of course, based on that model, we will roll it out to all the other areas where documentation is required. And I think that is a good step from a KHF perspective to really, transform the way MOH does their thing and digitize. Digitization is the way to go. And at this juncture, I want to ask John, I hope he's still around, from BOC. John.
My name is John. I work with BOC. Part of what we are doing as a PPP committee is to have public-private coordination. KHF, private sector, is engaged in various MOH technical working groups and platform. And the idea is to ensure there is good collaboration within the MOH and various technical groups looking at public-private partnership. The other one is public-private collaboration, strategy for health, poor understanding of public-private partnership in health, and the idea is to fast-track PPC rollout. I think there have been back and forth quite for a long time about public-private partnership. So national sensitization on PPC, both public and private sector players, both ways. We looking at having all the stakeholders come together, both in public and both in private sector, and having a kind of awareness to fast-track the PPC rollout. The other one is private sector engagement within the counties is still needed, and the idea is to have regular county engagement, because there are certain and there are so many things that private sector can do together with county government. And the idea is to keep on engaging the county government and bringing the county government and the private sector together to work on these opportunities and to enable the private sectors to plug in what they can be able to do within the county government. KHF has also collaborated with WHO, Think Well and Spark on Pair, provider engagement, and plans for phase 3 underway. So those are some of the initiatives we are taking or we've been pursuing as the PPP committee, and we continue doing the same. Thank you very much.
So we can take quick questions. Dr.
I must say that the KHF secretary is doing a good job. Thank you for the leadership of the chair and the board. The strategic plan is really forward-looking. It's really one that is very engaging from the stakeholders that we in the private sector need to have. I know some people look at my face and they see public sector, but now I've transformed. But I just wanted to make, it's a small, very minor. If no editor picks it up, then in your 4 pillars, the last one is reading B and not a D. But the main thing I wanted to talk about is just the issue of, as I see you explaining the direction you're taking, KHF is acquiring a momentum of engaging on a number of areas that will require that you really make use of the membership. Because just like you gave the example of some members have seconded staff to the secretariat, some members may not be able to second, but may have comparative advantage in certain areas. And what has come to my mind is, for example, the issues that came up, which you said already being articulated under the various committees and the presentation that you made. One of them is how certain macroeconomic policies are impacting negatively on the private sector in our journey towards universal health coverage. And the example for universal The one from in Kikuyu, the local manufacturer. Yes. I know when I was a young man, I visited them one time. The specific thing I wanted to talk about, that 0.5%, there must be some bigger macroeconomic issues that have made that happen. It's very sad and painful. What am I saying? I'm saying that within the membership of KHF, there may be some with strength in putting evidence-driven advocacy, helping with analytics on packaging and presentation and arguing the case from substance, not from voice. That's the only point I wanted to make an emphasis that also at the KEPSA level, appeal for restoration of what used to be the Prime Minister's Forum, where very high-level issues were discussed, cascaded, and solutions were found. And I'm not advocating for anybody, I'm just saying that it's important for some of these institutional development issues to come up very strongly, because I see KHF gathering a status that is going to be very high in this country. Thank you.
Thank you, Doc, for those kind words. For the typo, I think I'll ask the Secretary just to come to you so that we can fix that already before we share it. In terms of the Prime Minister's roundtables and things like that, I think the bottom line for us is what you said, data, analytics. And this is also one of the things that we need to have for NHIF as well. Because yes, we are talking, and we've been having that discussion, but as private sector, public sector has data, we know where the flaws are, but where is our data? So that's an important one, and I'll have a side discussion with you because I know you're a health economist. Yeah, thank you.
My name is Siddharth Ray. I represent Technology Associates, also known as Cranium Healthcare. So a couple of years ago, we were discussing about KHF's, one of your main agenda was to introduce the Health Index Exchange, HIE. And I remember I was part of it a long time ago. But when I go back to the fifth slide about ICT and what we are doing in mobile health, I don't see any direction in here. We are talking about county e-health bill, okay, COVID-19. We are still struggling to integrate with MOH system, which we have done 8 years ago. We achieved it. So the point is that the private ICT ecosystem is quite strong from our point of view, our experience. What we have achieved in the past years, our EDI partners like Savannah, LCT, CarePay even, and our newest partner, HealthX, what we have achieved is a very strong integration platform. And unfortunately, I don't see the direction of KHF onto that to achieve an universal health exchange, to bring NHIF sitting with data. After they've put out the system, the huge amount of data they are sitting on, the indexes this is a huge powerful. What is KHF doing to us? That is what is, concerning. That's all. Thank you.
Thank you for your feedback, and that's captured in the strategic plan. But I would want. We will have a discussion also because we need, as we roll out the, the strategic plan, that kind of, urgency, sense of urgency, and also to bring together. Because you're all sitting also in the ICT committee, but I think you bring in you bring in a very strong point of, we've started small, our systems plugging onto the, to the ministry so that we don't have to do manual data or, a platform. That's really small, and that started last year before we were thinking about, before we actually thought through the strategic plan. But definitely, whatever it is, it has to be transformational. So I would urge you to stay connected to the ICT committee, but more important is that we really need to transform the ICT agenda even within KHF. So thank you for that.
For me, it's just a follow-up on the same theme.
My
name is Kenneth Ogendo. I work for Living Goods Kenya, and I wanted to comment on the same pillar. And So from where I sit, in living goods, we are leveraging on health systems and technology to drive impact. And I really appreciate that you've already looked at the macro issues on the e-health bill, which provides a conducive environment for us to roll out e-health in this country. But again, if you look at COVID-19 pandemic, it exposed the soft underbelly of our health system. We've been very manual for a long time. And now we have a great opportunity, just to add to his point, for us to embrace innovation, technology, and data. So I would urge you to also put in your scope the DHP. DHP is a robust mechanism that is being put up by the Ministry of Health, and they want to have a data center in Afya House. And of course, they want to digitize everything that is happening within, from level 1 to level 6 or level 1, tier 1, tier 4, if you like. And hence, it would be great then to also bring on board, now that I can see KEPSA there, the big bodies like Safaricom and Airtel, who could actually whitelist the bundles that community health workers use. They could even help us provide mobile phones to the entire workforce within the health industry. So I think it would be great to also bring that out. And I think as KHF, you have got a great opportunity to influence Safaricom, DHP, and all the other players in the telecom for the betterment of our health. Thank you, and back to you.
Thank you. Thank you for your comments. We have taken note. Any other comments?
Good evening, everyone. My name is Henry Ngeso. I represent systems evaluation. We specialize in QI. My partner is Oduoro Tieno. Some of you are familiar with him. I'm the guy who does the back office work. Now, in regards to the concerns that have been raised by the previous speakers, I wanted to ask, in your strategy, where are you embracing third industrial revolution? Because currently we are at the tail end of the second industrial revolution. And for you to leap into the third industrial revolution, you have to embrace technology. We are talking transport internet, communication internet, energy internet. I didn't see that in your strategy. Thank you.
Maybe it's a terminology we are using, but we are very, very committed to technology in all its manifestations and ICT in all its manifestations and capabilities. So yes, part of what we want to do is to really leverage data, how we collect it, how we use it, how we integrate it. Actually, part of the conversation going on is having a number that can allow data portability for patients from one facility to the other. And we'll be having a conversation, uncomfortable for some people, about why we would want Huduma number to be there, never mind what the judiciary thinks. So yes, we are looking at it, and we need help because we see the value, but we can't see all the dimensions. We can only see some. So those who are in that space, we have an ICT committee, and it could use help to truly help us drive that agenda forward. And on this one, we are the ones to lead government. Innovation is the role of the private sector. Government is in many instances an adopter who turns to a regulator when enough people have adopted something. So yes, we want to provide the leadership and truly make healthcare leapfrog and catch up with many other industries that are ahead of us in the ICT and technology space.
Thank you, Chair. So it's the third industrial revolution, you said, or is it the fourth? That one. We'll take note for sure. So you've had it, we were thinking about it, but I think also if you call it third industrial, whatever, fourth industrial revolution, it will be more, urgent and impact, and, it will sound more like it's a sense of urgency. So thank you for that. Now, this screen has decided to misbehave just when we were going to tell you what's coming in next. But nevertheless, that screen is working. Before I hand over to Director Dr. Linus, I want to tell you what is coming up. You saw our calendar of events. Luckily, we've been able to tick off each one of them till now. So we have two major events coming up. We have the KHF CEOs Forum, which is on 7th of April at Serena, all booked, fully sponsored by KCB and Strathmore, so we must appreciate them for that. We also got a late sponsor that came on board, Amref Flying Doctors, so they'll also be exhibiting. For those of you who might want to come and pull up your banners, we will accept that at a small fee. And remember, this is just a small contribution to the operations of the organization because we only primarily depend on members' fees, and members' fees is only $50,000 for corporates and $10,000 for associations per year. So if you can support us, like our friends have supported us today, we really appreciate. But we urge all the CEOs, the leads of the organizations to please mark the date. The board decided it's going to be cocktail format, because with cocktail format you can actually network better and more. It's more impactful than when you're seated on round table. So please mark the date. More important, on the 25th, 26th, and 27th of May, we have the East Africa Health Expo that is organized by the SDG Partnership Platform. Open Fences is an organization of Strathmore Business School, and also Strathmore Business School, in collaboration with the Ministry of Health, have been kind enough to say we are coming on board, and we will bring the regional stakeholders on board as well. So the theme is East Africa as a hub for specialized medical care, investments in health, and innovative healthcare solutions. So we'll be sending out invitations for partnership for sponsors. And please take note that our communications come from KHF at either of us at khf.co.ke. I know there are a couple of other parties that have been pending to invite from KHF. Please, if that happens, we already got a complaint from one of the members, and we have taken it up with data protection because it was a breach of data privacy. So for those of you who may have received communication that is purported to come from KH something, please let us know. We already got one. We have taken the necessary corrective actions to inform the data protection, and we have evidence of how the data leaked. So that is very important. We take your data very seriously, and please report to us any of those unethical practices. So East Africa as a hub for specialized medical care, investment in health, and innovative health solutions. Please mark the date. If you have regional colleagues or investors who might want to come in to sponsor, to showcase, and we will even have online booths, which will stay online active for 3 months or so at a very reasonable price. So both local and regional, even international, you can showcase your services online. So we will be sending out a call out by the end of tomorrow latest. So please mark those 2 dates. And then after that, we will now inform you what are the next. Maybe what I must mention is that in view of the expo happening in May, our AGM will happen in June. But we will communicate again when the AGM is going to happen, but it will not happen later than mid of June. But we are currently undergoing the audit process for the 2021 financial year, which will now also, So with that, having said that, I want to invite it's not Dr. Wala, But we will invite Dr. Linus to do the necessary, unless there are any questions. I think we can open it to questions. And after Linus does the vote of thanks, then tea will be served and you can continue networking. So thank you. It's been a pleasure hosting you. And over to Dr. Linus Ndegwa. Thank you.
Thank you very much, CEO. Please mpigie makofi. I must say for me that this is an ambush, but I'm glad to do it because Elizabeth Walla and myself are very good friends. First and foremost is to thank Global Fund for sponsoring this members meeting through Kenya Coordination Mechanism, Principal Recipient 1, Kenya Red Cross, Principal Recipient 2, AMREF, and also the National Treasury. We really thank you for your support. You know, I'm a board member seated somewhere in the Kenya Medical Practitioners and Dentists Council, and we have a representative from the Treasury. So in one document, his name was written, and then he said alternate member, National Treasury. So he stood up on a point of order and said, my name is correct, but I'm representative to the National Treasury. So we had to change it from National Treasury to the National Treasury, and that's why CEO calls them TNT, the National Treasury. Would like to also give thanks to KEPSA. Of course, we are a brainchild of KEPSA as well, the private health sector body. My next thanks goes to all the organizations and the associations seated here. Thank you very much for coming. We really appreciate the feedback that you've given us. We look forward to these membership meetings so that we can get more engagement and see where we can improve. And we really, really thank you for your continuous engagement. As the CEO has said, kindly send your representatives to the committees so that we can get maximum involvement. I also want to thank the committee chairs, each and every one of them, who helped to put together the report, and those who are present here, and for your tireless efforts in terms of ensuring that KHF is represented in each and every sector. Then we also want to give thanks to the board members who made time to be present, including our super chair and CEO, for finding time and also being with us. We don't take it for granted that you're all here. I want to thank our exhibitors, health techs at the back there. Please find time to pass through their exhibition right there. And thank you very much for supporting our organization, our federation, KHF. And we look forward to other members and associations playing a similar role during members' meetings and also the upcoming events. I want to thank the hotel for the wonderful setup and the meals that you have had and are yet to have. I hope we can also get feedback on venue, on how we are doing as the federation, so that we know how to better serve you. I want to thank the KHF Secretariat, led by the CEO herself. You have heard that she has mentioned a few challenges. One of the things that we did in the strategic plan is plan on how to beef up the Secretariat and further strengthen it, because as you are aware, the board members do have other engagements and may not be there full-time. And in fact, that was also one strategic direction that we were told to keep in mind, that we are not executive board members, we are not there full-time, so the Secretariat should be there to support. So I want to give a round of applause to our KHF Secretariat for keeping us together. Last but not least, this photography team that is here with us. These beautiful pictures that you see the CEO putting up is not by, it's by design. And the team here that normally takes the photos are the ones in charge, and we really want to thank you for that. CEO, maybe you can tell us whether our pictures will be available, whether there'll be a share Google Drive. But yes, we really want to thank the photography team. Having said that, asanteni sana, and we look forward to engaging more on the members' events. I know there's a CEO WhatsApp group that we have created for further communication and better correspondence, so that we can all keep in touch in terms of the KHF community. Without much further ado, I'd like to thank you all. Asante.